Hi guys, we'll be starting in 2 minutes. We're waiting for two more people to join in and we'll be starting soon.
Hello. Yes, Sabrina. Hello.
Hello.
We will start in 5 minutes.
Yeah, sure.
Okay, sir.
Unmute. We can start recording on this.
Good morning, everybody. Let's start. I think we've waited enough and let others just join in. I think we did a kind of a debrief in the end yesterday, but I just thought raat gayi, baat gayi ho jati hai. So let's see. What do we remember of infant mortality rate, for example? Can somebody just try to anybody? Here, there, anywhere.
So, what do we think about infant?
Yesterday we talked about infant quite a few times. So what do you remember of it?
So the most important learning for the infant mortality rate or the takeaway was that the number of years that the mother has invested in her education would certainly reduce the infant mortality rate and would increase the chances of a child surviving and not perish.
Okay. So, but what is infant mortality rate? Can somebody also? Go ahead.
It was all about learning about health, what public health is, what are the determinants which impact the health. So we also talked about the equity. We also talked about the justice. So
I just wanted to come back. Faizan, thanks for that. I'm just saying, what do we, because I use the term quite often, infant mortality rate. So I was just checking back that, did you get that, what is infant mortality rate? I think with your IIPS background, you might be remembering it better than others. So just.
Of course.
What is infant and what is infant mortality rate?
Infant mortality rate is the death of a child below 1 year, I mean.
Yeah, before completing the first birthday, right? Correct. And we express it as a number of children who are dying in a year
1,000
divided by live births. right, per 1,000 live births, right? So just remember, and I tried to say this, that whenever we have to compare the health status of two different geographical areas, communities, countries, whatever, we normally compare the IMR because it's considered to be, that's again a debatable thing, but all over, I think we all agree that it's the most comprehensive health indicator, right? That सब कुछ समझ आता है उसके अंदर. So इसलिए I thought I'll just revise this in the morning before we go further. Thanks, Sabrina. And what about total fertility rate? कुछ याद है कि वो क्या बात की थी हमने? This is slightly technical and because it's got to do with a bit of statistics today, so इसलिए सोचा कि उससे start करता हूँ.
There's the average number of children born to a woman in the reproductive age. So
okay, correct. So yeah, I mean, loosely said, I mean, the definition is a bit cocky in this, but yeah, more or less it is about an average amount of a number of children that a woman within the reproductive age group, which we loosely define as 15 to 49, though children can be born even at 10, 11 or something like that, but 15 to 49, we have kind of said that this will be the total fertility rate, right? And you remember we had used the word replacement rate yesterday? What was
yes.
that? Yeah.
So yeah, replacement rate is like, when one person replaces another person. It's a kind of, there's a balance in the constant population growth will be there.
So how much should that be normally for any
that's
society?
2.1. Usually it's 2.1.
So it's
if it goes
2.1.
below
So
2.1, then it's,
a couple, a male and female, give birth to two people, and we keep 10% extra kind of a thing. Sorry, 0.5% extra for children to be who die before they become adults. So that much. So it's generally considered to be 2.1. That's the replacement rate. If it's anything less, you will probably need immigrants from other places to look after your older, and it's a burden on the economy otherwise, because as more and more people get aged, there'll be very few economic hands to economically productive hands. So in development, we should be looking at all this. So that's why I thought I'll start the day with that. There's another term which I didn't use much yesterday, but has been the focus of our health system for a long time, and that's what we call an MMR, the maternal mortality ratio. So there's something called maternal mortality rate and maternal mortality ratio, right? And there's a slight difference in it, but we normally talk about the maternal mortality ratio when we say MMR. And that's because the numerator and denominator are two different things. Like IMR, when we talked about, we said infant mortality rate. So out of 1,000 children born, how many of them died, right? So it's directly there. But in the MMR, what we are seeing is how many mothers die to give birth to 100,000 live births. So earlier, this was also calculated at 100 live births, then 1,000 live births, then 10,000 live births. Gradually, we've come to 1 lakh live births. How many women die? Because you can't say 0.3 women died. No, right? So gradually, lesser and lesser women have been dying out of childbirth and this thing. But it's not only childbirth, but during pregnancy, during delivery, and till 6 weeks after. Usually that's what the period when we count maternal mortality ratio. So women who die either during pregnancy or during delivery or till 6 weeks after, right? So that becomes the numerator, and below is the number of live births. So you look at it over 1 lakh live births, 100,000 live births. And so if you look at maternal mortality rate, then it would be of all the women who get pregnant, and of that, how many are dying, then it will become a rate. Here it is about how many children get born and live births at that versus, so that's why it's called a ratio, not a rate, right? If it was a rate, then it should be the denominator and numerator should be similar. Now, what I wanted to point out in MMRs is that when we have moved, a lot of our health.
Are we sharing the screen like PPTs?
No. Right now, just speaking off the cuff.
Okay.
So thanks, Faidan, for remembering. So MMR has been the focus of many of our mother and child health services. And that's why I wanted to come to it. And with that, your maternal mortality ratio in some countries is down to 1 per lakh. Right? Sometimes we don't even know because, some of the countries have very small population, especially Scandinavian countries. The populations are so low that you don't 1 lakh live births in a year. So sometimes in 7 years, there's no death, and suddenly one death it'll suddenly shoot up to 3. It'll again come down. So, but do remember that no new medicine technology has come in the last 40 years to save women. And yet, many of these countries reached a MMR of 0 or 1 so many years ago. And I keep teasing this, that, they didn't go in for sending a craft to the moon or, having nuclear weapons, but they invested their science and technology and money to save women. And we are still struggling. When we had got when we set our goals for the year 2000, at that time we had said we will reach a maternal mortality ratio of 60. So imagine 60 times more than the best in the world. We only aimed for that, and we have not still reached it. Right? The place where we come from, Assam, for the first time last year, it is not the worst in India. Earlier, we used to be struggling. When I reached Assam in the year 2000, most of the rural areas, we had 5,000 to 7,000 MMR, which would mean 5% women were dying, for every 100 children born, 5 or 7 in the rural areas. But composite in the entire thing, it was around 1,500. Even today, it would be around 400, 500, but the government records, because of whatever the way SRS is done. Have you heard of SRS anyway?
Sample registration system.
Yes, the sample registration system. It's run by the Registrar General of India in the Home Ministry, actually. And it keeps giving you feedback about the population, and they keep doing different household level tests. So there, for the first time, we are no longer the worst. Assam is no longer the worst in India. And I'll come to those statistics later.
I think this year it came like after some 8 or 9 years. SRS.
What the MMRs?
No, SRS reports. I think, has it come or not? I didn't check.
No. The SRS, the data was still for up to 2022, but it was released only in 2025. The last MMR thing was done in
2017.
8 years ago. Yeah. So, because MMR, you need a certain amount of births to be sure that this is the MMR figure. So small states, we don't get an MMR figure now, because places like Sikkim has got 6 lakh population. So how many children will be born in a year? So how many years will it take to get some sense of statistic there? So it becomes difficult, because just one death here and there will make the figures jump very high. The numerator jumps straight away. So we don't normally comment on small states on MMR, but yes, IMR and all. So just wanted to say that. But remember, now MMR continues to be the focus of India, because it's shameful that we have not been able to bring it down, and we have one of the worst in the world. Whereas, so many countries have brought it down to 0 and 1. But today, if you look at the amount of women who are dying, if the government's MMR statistics are right, we are losing around 35,000 to 40,000 women per year. But when you look at, on the other hand, the government's own estimates of dowry deaths due to burns in India is 7 per year. That's the government's estimates, So should it not be a public health issue? If we agreed yesterday that public health is about preventing any unnecessary deaths, disability, or disease, then it should be a public health issue. But then public health does not, up till now has not really bothered. It's still a women and child development issue. It's still a social welfare issue. And so that's where we need to redefine public health also. just because maternal health and maternal mortality comes to the hospitals and comes to the health system, and hence we must prevent it, so it becomes a public health issue. And since yesterday I've been saying, just government health is not public health. Public health is about preventing any unnecessary deaths and disability which technology of that day or the efforts of that day or the money of that day can prevent. We should be able to prevent, right? So that's why I tried to bring up this morning about maternal mortality ratio, right? And we'll be listening to some of this, whenever we are talking. Is that okay? Is that clear a bit, MMR and its relation with public health?
Yes, sir.
Okay. As promised, I think, I was waiting for a few more people actually, if possible, because one of our agendas is also to introduce the Northeast to all of us here. And I think a lot of our examples have been coming from there. And so I just thought, besides the small reels and videos that you see from touristy places in the Northeast, which actually replaces the earlier version that everybody thought there was only 3 news from the Northeast: bomb blasts, malaria, or floods. There was usually no 4th news coming out from the Northeast. And it's been happily replaced now with only touristy this thing. But there is a lot to be learned from the Northeast, and one of, I think, our agendas is to Northeastize the mainstream rather than mainstream the Northeast. It's a lot to learn, right? And so I'll give a few statistics and introduction which may not be currently in your mind. So I just thought I'll take some time on doing that. Is that okay? Can you just put on this thing? The PowerPoint, just open the PowerPoint first. And the second day, that folder saying second day, JGU. Yeah, PPT होगा Northeast India. Yeah. Oh, yeah. Share it. I ensure that they are all listening to us. Yesterday, we had this challenge quite a few times. Meanwhile, can you introduce yourself? The 2-3 of you who joined today. You can switch on the mic so that others can also listen whenever you speak.
Hi, my name is Tuti. I'm also a development practice student here doing my master's. So this was a pretty intriguing session having. I couldn't make it yesterday, but look forward to.
Okay. Thanks. Welcome, Shruti.
Hi everyone. I am Omuz Mishra from Global Library, and when I see the topic and all, I was much more connected to me, and I want to learn about these things, so I joined. Thank you.
Thank you. Welcome.
Hi, I'm Khushi, and I was there in the session yesterday.
Yesterday, I remember the name here. Okay.
CMC development practice student.
Okay, so a brief about Northeast India. I'll just go through, and I'm not going to show you the beautiful pictures from the Northeast, and because I think that you can all get on YouTube and other things. So generally, we used to call this as 7 sister states in the Northeast, but now we've added the 8th one, and that's Sikkim for various reasons, and so it's now 8. Don't ask me why it's a gender bias of sisters only.
I
Younger
think
brother.
Assam was added in the end, like there was 7 sisters were excluding Assam, is it?
Excluding
or is
Sikkim.
it like,
No, excluding Sikkim.
is it? Okay.
Sikkim is a bit disjointed from the Northeast, so that's why.
Okay.
I'll show the map. So here's the
Sure.
map. We can point out from here. Yeah, okay. But I can't see.
I can see Sikkim is far left.
No, yeah.
Near
So Sikkim
Bhutan.
is disconnected in the sense that there is a portion of North Bengal which is part of the state of Bengal. I was trying, but the moment it goes on the screen, I can't. You can't see the pointer on the screen here. This is Sikkim. Yeah, they won't be able to see. Right, and this green portion, this is where Assam starts. So this part is North Bengal, which is part of West Bengal. So this whole thing is Assam. It's mainly two river plains. So one is the Brahmaputra River, which is flowing from east to west. And that's how we say Upper Assam and Lower Assam. But then this portion is also Assam, and this is what we call the Barak Valley here. So there are two areas of Assam. Also, Assam is mainly dominated by people who speak Assamese. And this area, their Bengali speaking is dominant in the Nasima. Right? So that area. Okay. So this is Assam makes up for about 60-65% of the population of the Northeast. So keep that in mind when you're thinking about the Northeast. North of it is Arunachal. Right? And Arunachal actually geographically is bigger than Assam. But not even, I think, 5% of the population of Assam. So things are really far, and very few people here and there. One of the lowest population densities, and it envelopes the upper part of Assam. If you notice, it's not only in the north. Arunachal, in our minds, usually is only north of Assam. It's actually also east and south of Assam, right? And that's where Arunachal is touching not just Tibet on the north, but on the eastern and southern side, it's also connected to Myanmar. Then you have Nagaland here, right, which is east of Assam. And then south of it is Manipur. Manipur and Tripura were the two kingdoms till 1949, actually. They were still kingdoms which finally merged with the Indian state. South of it, in the end, is Mizoram. Right? Mizoram on one side has got Myanmar, and on the other side, there's Bangladesh there. Tripura is enveloped almost entirely by Bangladesh. Right? And I'll come to individual things later on. Just wanted to say that just for a short distance, you'll notice here in this area, westernmost part of Assam, it is touching Bangladesh. Otherwise, and then here also it's touching Bangladesh. And you must be hearing all Bangladeshi coming in and whatnot. Well, we have not really found so many, at least Bengali Muslims as what people expected. So only out of 18 lakh who could not get registered in the NRC, around 5.5 lakhs are Bengali Muslims. A whole lot others are Bengali Hindus also, besides some other people who could not get documents. So this Bangladeshi thing, which has been talked about. So people, when they're Bangladeshis, actually, as far as Assamese are concerned, it's also Bengali Hindus, not just Bengali Muslims, right? Because they felt that the language and culture will get swamped. Sikkim, as you saw, is up there next to China or Tibet, what we call, right? And in between, this is Bhutan. A large part of where I have worked in the field has been on the borders of Bhutan, called the Chirang district. It's part of Bodoland. Bodoland is roughly from this part of Arunachal, right up there above the Brahmaputra mainly. All right. So there are 5 districts there. Okay. I also wanted to just because people tend to remember Chicken's Neck. Everybody's heard of Chicken's Neck? Yes. It's a 18 to 22 kilometers border between Nepal and Bangladesh, through which all our trains have to travel. So in one sense, militarily, strategically, it's considered something which, if it gets attacked, the whole Northeast may get cut off. And if you notice here, Sikkim, and between Sikkim and Bhutan, Tibet or China, you must have heard of Doklam. that area, or good old time when we used to also talk about Nathula. Those passes are here, and from there it's just about less than 100 kilometers actually. 50 kilometers by crow's flight. So you can actually see and bombard it from China. So that's why India is a bit scared about this area. But these days we have started talking about another chicken's neck now, which India is now, because you might remember that Mohammad Yunus, the current caretaker prime minister of Bangladesh, started talking about chicken's neck and whatnot. So now the Indian Observer Group and all this Observer Research Foundation, they started talking about this chicken's neck, that we can also cut off some parts of Bangladesh, because from the southernmost part of Tripura to Chittagong you might have heard of, during our time, it was very famous in the 71 war. It's just 72 kilometers. And India is actually, with the previous prime minister in tow, we've made a nice, quick running bridge there on the river Feni. So we can actually reach it within 1.5 hours. Chittagong. So this is sum total of, just the map, the geographical thing. Just wanted you to also see, this is the anthropological map of the Northeast India. You can probably read, there are so many different communities here, and still we can't show all the communities. With every language, we all know that there's a bit of culture which goes along with language, and we have 238 registered languages in the Northeast. Assam itself has probably 175. Oh, thanks. Who did that? Very nice. Anthropological map. Yeah. So if you notice, in places it's in Bodo Kachari, so that's a tribe. Then you have, below that, you'll see Garo. They're similar. Garo and Bodos are very similar, but Garos are matrilineal still. Whole of Meghalaya has got actually 3 major tribes, the Garos, the Khasis, and the Jayantiyas. And all of them are matrilineal, not matriarchal, but matrilineal. Right? Assam has got, here there would be Karbis and Dimasas. And Dimasa Kachari is also a kind of similar to the Bodos. You must have heard of Dimapur, and Dimasa Kachari, the kingdom, used to be headquarters from Dimapur, which is practically in the plains of Nagaland. Then you have in Arunachal, you have so many different tribes. Here you would have the Mompas, which are mainly Buddhist, and then Sherdukpens on this side. So you have Adis and Nishis, which are the dominant tribes in Arunachal. But there are so many others. So if I look at just Arunachal, there'll be around 120 languages here, registered languages. Some of these languages are registered with just 5,000 people, 7,000 people, that's all. But all of them, with languages and culture, there also comes like an ethnic pride. And that's why you keep hearing so many troubles coming from Northeast, is because people are trying to assert their identity, right? And it's especially with democracy, you tend to kind of look at your identity in numbers because you want representation there. But this whole of Northeast gives you only 25 MPs in the country, right? So it's not enough to represent so many different communities. And that's one of the reasons why there's strife. So Naga, for example, there's no tribe as Naga actually. We call Naga tribes. So there are a group of 18 tribes, the 18 major tribes, which today are called Nagaland. And each of them has got a dominance in one area. And what Gandhi used to talk about village republics, we have seen Nagaland as village republics. So I remember, I think in 2003 or 4, they invited me for, one of the tribes invited me as a chief guest on the occasion of declaring 25% of their village land as a sanctuary, as a wildlife sanctuary. Do you know how many square kilometers was this 25%? It was 75,000 hectares. So that village owns 300,000 hectares. So it's like a village republic. They don't allow the forest department to come in without permission. Whereas everywhere else we think that forest department is in charge of the forests. Nagaland has retained the autonomy over forests. And many of these villages are like republics. You have a village council which runs for 30 years, and their names will come up on Shilalekh, as we call it, on stone, there'll be engraved names. And so there is a hierarchy, there is a governance which is very democratic. And so they sometimes mock at our democracy because you really have representative democracy, though, of course, male dominated in most parts. But yeah. Manipur has come into the limelight for some time now, and I'll come to it later on. It's got the dominant community or the dominant population around 50 odd percent lives in only 10% of the land, which is a river plain, like a valley. And the rest in the hills are all tribals. But they have around 90% because tribals are allowed to have autonomy in their areas. So land is a very important part of it. So 90% of land is occupied by 40% people. So that's why the new thing has come up, trouble between the Meiteis and so the Meiteis are Vaishnavites, but they want now a scheduled tribe status. At the time of independence, they felt that they were the kings and rulers, and also obviously they didn't want any reservations. But today they feel that the reservations have got the better of them, and so they are kind of asking for. Then you have Mizoram, and so Mizos. There was again, I think if we go back about less than 100 years, there was nothing called a Mizo tribe, but they merged all small tribal identities together and created a Mizo tribe. So the Lushais, Mars, Paites, so some of them, they called themselves Mizos and are very proud to be here. But I'll come to it again later on. Tripura at the time of independence had only 30% non-tribals. But today, around 70% of it is non-tribal. Because of immigration, when East Pakistan was being made, at that time, a lot of Hindus moved to Tripura. And so today, around 70% of population is. This is another way to look at it. As Inakshi said, so Sikkim is their younger brother, but disjointed a bit. It's mainly because Northeast Council, which has been formed by now called Donor Department of Northeast Region, they have included Sikkim for development purposes and that thing. So it's become 8 states in the Northeast, as they say. Yeah. I mean, we still have a lot of rainforests. I don't know if people know about rainforests. Rainforests are considered those forests which have like 7 layers, 7 canopies. So you don't require clouds to rain. Just the 7 canopies is enough to create rain within themselves, right? So that's why they're called rainforests. So we still have rainforests, especially in Upper Assam and Arunachal border. We have a good amount of this thing. In India, basically, you have rainforests only in Andaman Nicobar, Kerala, Western Ghats, and in the Northeast. The only place in India where you'll get one-horned rhino, only place probably you'll get golden langur. We have 20 national parks. Around 50% of Indian tea is from here, and 80% of Indian tea exports are from Assam. India's oil reserves, including those which are offshore, about 26% are here, but we are producing only 14% of our crude oil. In fact, we had set up so many refineries that very close to where I worked so many years, Bongaigaon you might have heard of. The oil that it is refining today is coming from Texas, all the way, right? So Northeast is now refining oil from Texas because we don't have enough oil compared to the demand that we have in India, as our GDP grows, we are not producing enough oil. And to refine it, obviously you can't use crude oil. So we are importing it from so many different places. Just a bit of Assam, I'm trying to remind, between each time I'll show you the political map again so that people don't miss it. Why I can't show this? Can't see it so easily. इसके ऊपर दिखता नहीं है. If it's bright, I think. Right? नहीं दिखता वो. When I put it on the screen, दिखता नहीं. Everything is bright. हाँ, white जहाँ मतलब कलर पर गायब हो जाता, उसके ऊपर नहीं दिखा. अभी दिख रहा.
ज़्यादा डीपली ध्यान देने से
हाँ, ध्यान देना पड़ता है. So anyway, so this is Assam. So I'm just speaking about Assam for the time being. As I said, about 65% of population, 68% of population in the Northeast is in Assam. And I'm giving only 2011 statistics because the last census was not done. 3.4 crores population. And when I'm saying 45% people claim that their mother tongue is Assamese, it also means that a majority do not speak Assamese as their mother tongue. Right? And that's why the threat perception that, others will swamp us. Bengali, Bodo, Mishing, these are Bodo and Mishing, of course, are tribal languages. Karbi, Dimasa, Santali, everything is spoken here. Santali, Sadari, Orao, Kuruk, these are actually, if you know, these were tribes which were there in today's Jharkhand, Chota Nagpur Plateau. But we also had Telugu-speaking people who had come because of the tea industry. They came as labor from as far as, Tamil Nadu also. A lot of Telugu people actually, Telugu-speaking people and these make up today for about 18 to 20% of the population of Assam. But they don't have a scheduled tribe status here. So we call them Adivasis. So, and whereas in many places, scheduled tribe and Adivasi is the same word, for us in Assam, Adivasi does not mean scheduled tribe. Scheduled tribe, the word is used only for indigenous sources, scheduled tribes. So these are exogenous coming from the other parts and hence only called Adivasis. They've been asking for scheduled tribe status but have not got. Assam also has one of the largest, the largest inhabited river island in the world called Majuli, roughly here. This part is Majuli, just north of Jorhat, if you can see, in Upper Assam. About 150,000 population staying on an island. Luckily now from the northern side, we have a bridge which is connecting it. So a fascinating place which has got a lot of monasteries from the Vaishnav faith. So in Upper Assam, we have the Vaishnav faith, which is predominant. It doesn't have idol worship and, has some very interesting concepts. Mainly Bhagavad is kept on a pedestal and uski puja hoti hai, right? So we, as I said, we talk about Upper Assam and Lower Assam as the Brahmaputra Valley is concerned. So the western part will be seen as Lower Assam. And because at one time it was, the capital of Assam was in Upper Assam, the development indicators of Upper Assam was far better than that of Lower Assam. And if some people might be knowing that, we had the Ahom kingdom there, empire in fact. So they came, a prince from southern China, Thailand border, came with around 8 to 10,000 of his clanmen and came and established a kingdom here through what is today called Nagaland. They came here and established themselves here and set up an empire which went on for almost from 1250, I think, from 1250 onwards roughly. So till about 1800, so 600 years of rule that they had, and quite peaceful. They had, they prevented attacks from other places, and in that sense, there was a peaceful rule for a long time, and they integrated, these 10,000 people actually integrated very well into the society. And it was, which I find it very interesting. It's something like Israel that they had done, that they had established, farmer soldiers. So there would be Decca. Today also there'll be surname called Decca. They have to supply 10 people. A person, Decca, would be in charge of 10 people who will have to supply this to the empire or to the kingdom. Then there would be Saikia, who were in charge of 100 people. Then Hazarika on 1,000 people. Yeah, so you must be hearing these names, and these have a meaning in Assam. Right. 61% are Hindus, about 34% Muslims, of which around 2 to 2.5%, 3% would be Assamese-speaking Muslims, and the rest would be Bengali-speaking Muslims, right? Which often in local, this thing is called Bangladeshi. But actually, when you look at it, they came much before the original people came much before Bangladesh was formed. Either even before East Pakistan was formed, when Assam was part of Bengal, or later on, when the borders were porous and Northeast also did not have so much of defense and whatnot. So people also came because there was enough land there compared to Bangladesh. The density of population was very heavy. In fact, in 1940s, if you remember the 43 Bengal famine, so 42 also had a famine, 41 also had a famine, 43 was a bigger famine where so many people died in Bengal. When this Bengal is concerned, Assam was next door. Bengal was also what is today Bangladesh, right? So the British government actually connived with local people to, migrate northwards, occupy land and grow rice, paddy, because they were good farmers. And in some of these areas, there were forests and, so the forests had to be cut down. There was a lot of malaria in it. So a lot of these people, Bengali Muslim farmers from Bangladesh, upper part of Bangladesh, they migrated upwards, northwards. So a lot of the history is there, right? Now, I also wanted to, because this is mainly on public health, and so we thought that I'll also tell you about this birth rates and death rates here. When I'm talking about birth rate is 19.8 per 1,000 population. So it's almost like 2% birth rate. And we call this a crude birth rate, right? Similarly, we have a crude death rate, which means 6%, sorry, not 6%, 6 per 1,000 people will be dying every year. IMR is 30 per 1,000 population, sorry, per 1,000 live births. And MMR is 125. So see, MMR is still very high. Live births, I think the government is now claiming that it's come down below even 80. I'm not this is the last when we recorded, so I'm just leaving it at that. We have 35 districts and, international borders with Bhutan and Bangladesh. So many parts, like people coming to my area where I was working, because being next to Bhutan, any foreigner comes to my house, I have to register with the Home Ministry. I cannot allow him to stay there. In my house also. Right? So I have to declare my house as a guest house kind of a thing, register online, only then am I allowed to keep somebody. So normally now what we do is just keep them in hotels. It becomes so difficult. Right. So these are, but Assam, by and large, the insurgency has come down a lot. So we had Bodo insurgency, we had Adivasi insurgency, we had Assam Alpha, we must have heard of. So they're more, their power has now reduced a lot, but I won't say it's totally free from insurgency even today. Right? Violence is subterranean. This whole demography, identity, all this, Thank you. Okay. Floods have been a regular feature in Assam. And but it's very heartening is that in the last 10 odd years, the role of NGOs has gone down. The government itself handles most of the flood relief now. Earlier, there was a lot of, I wouldn't say 10, but 15, 20 years now, there's been a turn. Earlier, NGOs used to be seen to be working only during flood relief every year. But in the last, also because of climate change, we have very funny kind of floods now. We have what we call rainless floods, because the clouds are so high that they go and pour out in Arunachal or Bhutan, and the water comes tumbling down into the rivers and creates floods here, right? And it happens there are flash floods very often. So it's very peculiar. In the last 10 years, climate change has made a huge difference, and it also brought down malaria. This thing is that malaria has come down because of the climate change, because it comes in torrents now. Earlier, between May and July, you had rain for continuous, I think 7-10 days. You will not even have more than half an hour of a break. It'll keep raining. So clothes will get black with mildew, won't dry at all. So mushkil hoti thi. Today, you don't have that. suddenly it will rain and then 7 days you have sunshine, or you don't have any rains. So in that, all the mosquito reservoirs get washed off, and that's where malaria is practically down to very small amounts. Earlier, as a doctor, I can tell you that till about 2007-8, every hospitals, every ward between say May to November used to be full of only malaria patients. Today we hardly see a malaria patient. Right? Okay, I won't bore you with too much of Assam then, though. As I said, many of these states are very interesting, and Arunachal. So as I pointed out, it's north. The yellow part that you can see is north, east, as well as a bit south of Assam. Right. If you can notice, on the western side, you have Tawang. Tawang, till 1959, used to pay its taxes to Tibet.
That's what China claims.
Yeah, that's why the Chinese claim, because they claim suzerainty over Tibet, right? And of course, they were having their cultural revolution in the late 50s, and they didn't have so much of control over Tibet. So, but then when India tried to regain some boundary because there was a dispute in McMahon Line, so they kind of, right? So they kind of got very upset, and they sent their troops all the way from Tawang side. They came almost till Tezpur in Assam. Chinese troops came right till that point and then went back. Maybe it was too difficult for them to establish a supply line till there, so they went back. Or maybe it was just to teach a lesson that please don't disturb us at this moment. We are busy with our own development of. They were doing the cultural revolution and whatnot. So as I said, the Nishi and the Adi tribes, which are in the central part of Arunachal Pradesh, they're there. But the northern part is what we call the Lesser Himalayas in one sense. Middle of where you can see Arunachal, mid of Arunachal, east to west if you see. You have the Himalayas continuing till about 1828, between 22,000 feet to the west, and then about 15,000 as we go down. It's very hilly terrain on the northern side. So Himalayas separate us from Tibet actually. But for a long part of time, this was, a large part of Western Arunachal Pradesh was under either Bhutan or Tibet. The 6th Dalai Lama, if I'm not wrong, 5th or the 6th Dalai Lama actually was from Tawang. Yeah, so that's why they're also, the Tibet Dalai Lama's affinity towards India, and then the China's claim over, because they claim Tibet, they claim Tawang and Arunachal Pradesh also. So again, many tribes, actually about 120 odd tribes everywhere around. In fact, there are Naga tribes there also. In southern part of Arunachal Pradesh, where you see it joining with Nagaland, you will see Naga tribes there also. And so the Naga insurgents, they want a Naga limb which has these parts also. Okay. And because at one time, Nagaland, Arunachal Pradesh, Meghalaya, and Mizoram all were part of Assam. So there's a lot of these tribes also in Assam. Right? Gradually, all the hill tracts got separated out into separate states. And Assam was left with the plains only. Right? Interestingly, till about 2006, Government of India did not allow Christian missionary schools in Arunachal. But after that, they allowed. Till that time, actually, if I'm only the outside schools were, except for the government, were Vivekanand Kendra schools, which is actually started by Eknath Ranade, the Vivekanand Kendra Vidyalayas, which is Eknath Ranade was an RSS fellow. So only their schools were allowed, apart from they didn't allow Christian missionaries. But from 2007 onwards, they've allowed the same, because there was a demand for good missionary schools, Christian schools, which others in the Northeast were. But by now, 30% population by 2011 was already Christian. We don't know the figure before that. It's not so easy to measure. But 29% people identify themselves as Hindus, whereas others, they call themselves now a Doni Polo, which is an animist religion, but now getting organized, more and more organized. So this is the major, around 68% of population is what we call ST population. Around 175 languages. In some places 120, some places 112. But do understand that sometimes, the difference between dialect and language is a bit tricky. They say that unless you have a script, it will not be called a language. But if you listen to Javed Akhtar and all, he argues that a language can be written in many scripts. For example, Kashmiri can be written in Devanagari, Urdu, and at one time the Sharda script, right? So, and Urdu, which developed in India, is written in the Persian script, and Punjabi is written both in the Persian script as well as Gurmukhi. So he argues that you should not call a language is what is spoken widely, and it should not be based on this thing. But so that's why it's a bit tricky how many languages there are. But generally, we talk about 238 all over the Northeast. China and Myanmar borders are there. Mostly hilly, up to 21,000 feet high mountains are there. Infant mortality is 20 per thousand, which is quite low. Looking at the outreach of government health services, you can't possibly have government health services everywhere because populations are so sparse as you go up the hills. But yet, we also need to understand that in the hills, infections are not common. It's colder, people are staying so far away, so you don't get so many infections. So many of the tribes where outsiders have not come in and roads have not reached, actually your mortality rates are very low. So in parts of Nagaland, I have been, say, about 15 years ago, 20 years ago, I would find a lot of people with more than 130 years of age, 110, 130 years of age. So I was also quite shocked. But they had records that when the church came in 100 years ago, these people were already about 35, 40 years of age, and they are still surviving. And sometimes you can't even make out who is the father, who is the son. The father looks younger than the son, right? So it's an interesting place to be in. As I said, the health indicators are also sometimes, we are not even sure of the health indicators because populations are so sparse that, whether the government system is reaching out to those places to record it, we are not very sure. There's an inner line permit which is required, something like a visa for any non-Arunachali to enter, right? So you and I cannot go to this thing without an inner line permit, which has to be applied online and a bit before. Oh, I'm going alphabetically. Well, I could have gone. Okay, let's look at, again, you identified Manipur. Manipur is below Nagaland and to the west of Myanmar, where it's written. As I said, about 50% and more population is Meitei, of which a large part still consider themselves Hindu. The hill population is mainly Christian already. There are also plains people, Meiteis, who converted to Islam when the Myanmar invasion had taken place and all of them had run away to Sylhet area of Bengal, which is now Bangladesh. So at that time, a lot of people converted to Islam and also came back, and they're called Pangals. 40% is an ST population, and in the hills, it's about 89-90% people are STs, scheduled tribes. Around 60% but stay in the valley. And it's only 10% of the geographical area. So naturally, now people are started wondering, if the governments want more development work or so-called palm plantations and what, where will they do it? So they want the hills, but the hill people are not allowing the government to, they would decide, because tribals have a way of democracy that they will decide amongst themselves and then decide what to do, what not to do. So there's a kind of a tension between a very, the way governance is taking place now. It has 16 districts. The Myanmar border is there. 149 different mother tongues have been recorded here. But the lingua franca is the Manipuri language, which is actually the Meitei language. Right. Might be interesting for you that the Japanese and the INA had reached Imphal in 1944, and there was a Bhishan Ladai. बहुत बुरी लड़ाई हुई थी. And both in Kohima as well as Imphal. In 1944, of course, the British defeated the Japanese, and the Japanese had to retreat from there. And so INA also could, to some extent, had to retreat from there, because INA had joined Japan. Very recently, about a few years ago, Manipur also demanded an inner line permit, which actually was not there earlier. It was there in Nagaland and Arunachal and on the southern side, Mizoram, but not in not for Manipur. But now, lately, last few years, we require an airline permit to enter. But you can get it at the airport in case you go by air. I'm going alphabetically. Meghalaya, if you can see, is to the south of Assam. All hilly area. People fought for their separation from Assam. The plain people and tribe and hill people never, go around easily. It has happened everywhere in the country. So similar things were happening here. They were accusing the people in the plains to, कि हमारा सारा पैसा डेवलपमेंट का खा जाते हैं. So so वो लड़ाई बहुत दिन चली, आग जली, मतलब the hills were on fire actually. But there's a very interesting side to Meghalaya, how it was born, where in one sense violence stopped and then it was formed very peacefully. And there's sometimes read Initiatives of Change. There's an organization called Initiatives of Change, which is headquartered in Panchgani, and the Indian part of it is in Panchgani near Pune. And there is a history to it, how Meghalaya was formed by somebody saying sorry, by somebody saying sorry to many people, and then a meeting of hearts, and Meghalaya was carved out of Assam. So read about it sometime. I won't talk about it, but there's a Initiatives of Change has world. The head of the Indian unit is Rajmohan Gandhi, Gandhiji's grandson, and they worked all over the world to bring peace between communities. So one of their initiatives was here, earlier called Moral Rearmament, now called Initiatives of Change. So Meghalaya has 3 major tribes, as I said, and these are the Khasis, the Garos, and the Jayantiyas, and all matrilineal, not matriarchal, but matrilineal, right? So the parents will stay with the youngest daughter, and the women's name will be continued. I mean, the mother's name will be continued by everybody, and the land will go from the mother to the youngest daughter. But before she sells it, she has to take mama's permission. That's it. That patriarchy is there, but otherwise it's matrilineal. Khasi language is considered to be older than Tamil in India. The Khasis came later to India, to the Indian part, but the language is older, considered to be older, but of course people will fight about it. I don't want to increase the controversy. It's a very basic language, and it's the only non-Mongoloid tribe in the entire Northeast. This is what we call Austroasiatic tribe. And Austroasiatics, I mean, by the shape of the head, by various characteristics, the language, everything, they're closest to the Mundas in central India. Mundas, you must have heard of, Mundari or Kuruk, Bhasha. So they're very close to that. An interesting thing which very few people know is that in geology, so we are going through the epoch of Holocene. And in Holocene, normally they divide into at least 3 ages. This age is called the Meghalayan age all over the world. Even people in Meghalaya, unfortunately, don't know. Not everybody knows about it. And this was created because there's a Mamlu cave in which you can actually delineate the geology of the last 4,200 years. Right? And it's believed that around 4,200 years, why they call it a separate age was that's when all the major civilizations in the world ended, because we had a 100-year drought. around 100 years drought, which killed all the civilizations. So around 4,200 years means around between 1900 to 2100 BC, when many of the civilizations had died. And so that whole thing is available only in the Mamluk cave. And you have lovely caves there, 13, 14 kilometers long. You can, go into caves out there. So that's a very, so Meghalaya is some place to visit if you are interested in anthropology, geology. And it's just north of Bangladesh. So you can also see Bangladesh border. Sometimes, you'll see Lafarge cement, their limestone goes in trolleys to Bangladesh where their factory is. It goes so it crosses the border without a visa in one sense. So it's a very interesting place. There's a lot of coal, rat hole mining, all that is there. It has the highest infant mortality in whole of the Northeast, 34 per thousand still. But the birth rate also is one of the highest in the Northeast. It's very interesting. Here there's matrilineality, but there's some kind of allowance to have more children, and many of them die also. So the infant mortality rate there, we just did a study out there why people are refusing immunization. It's very interesting. And it's still one of the places where you'll find herbalists there. क्या वो जो हकीम नहीं है, हकीम का थोड़ा सा वो यूनानी सिस्टम में आ जाता है, उसमें heavy metals भी. Here basically herbal medicines. So herbal medicines are practiced a lot in Meghalaya. There's an interesting aside to Meghalaya also, in case people understand geology, kabhi padhi hogi to, if you have studied that. So when the Indian subcontinent plate broke off from the African continent at one time and then traveled northward to form the Himalayas by pushing across from the Gondwana land to the Bethwana land, and then the Himalayas rose. There wasn't enough space for that landmass towards the east, and that's where the land upturned. And that's why you get fossils, sea floor fossils in Meghalaya. The sea floor has come up totally out there. And that's where probably migration and all, so some people are saying, the Khasis were there even before this whole plate thing happened. So we don't know. So, but as far as we are concerned, we normally talk about Khasis having migrated from the Mon Khmer area. Khmer, is Cambodia, right? So Mon Khmer area se log migrate kiye the. Mizoram, again, I want to show you, is the southernmost part. Ek side pe Bangladesh, on one side you have Bangladesh and the other side you have Myanmar. Interesting for many reasons. About 30% of the population stays in its state capital, Aizawl. Just one city has more than 30% population. Very densely populated. It's my favorite state of India. When you will see the most disciplined traffic out there. You have shops without any shopkeepers. Of course, you'll find that in Nagaland and some other places also, but much more here than any other place. Where you can just put the money in, rate will be given, you put the money in, and that's it. That trust begets trust. You can see it in Mizoram. A lot of public service kind of thing is a very important tenet of life. I don't know how many of you know that 1966, Aizawl was bombed for 4 days by the Indian Air Force. Baghi ho gaye the. So they had captured the treasury, the armory, the Assam Rifles post was run over by the rebels there. And so Mrs. Gandhi ordered and never admitted it in parliament for a long time. I think Modi ji has been talking about it now. But then, anyway, people still expect some apology, but we have never apologized to them. But very forward-looking people in that sense, who only talk about insurgency as the disturbance. They don't like to live in the past. They look at the future. So it's interesting. You must be hearing about Mizoram. After Kerala, the highest literacy rate in the country, right? 87% are Christians, a lot Presbyterians in one sense. ST population makes up for around 94% population. There are a bit of Buddhists in the southernmost part, which is next to the Chakma area of Bangladesh earlier when Chittagong held tracts. They migrated to the Mizoram area. So the southernmost part have been there earlier also. So they have 2 autonomous councils here. IMR is as low as 13 per 1,000 live births, one of the lowest in the country. Right? You also require an inner line here too to enter. Nagaland, just north of Manipur and south of Arunachal, east of Assam. Here. As I said earlier, 18 major tribes who can't speak to each other except in a third language. So they speak Nagamese, which is a pidgin language of Indian, Hindi, Bengali, Assamese, all mixed. 86% population is ST. The state language, of course, in many parts of the Northeast, state language is English. So you'll find it funny. Not many people understand that English to Videshi bhasha hai. Many states have got it as an official language, right? We don't understand that. So how can we just dismiss it? And that's why the Indian rupee has got English in it. Because it was, so it's easier to talk to each other. And some of these, like Nagamese, you can't have a script for it. It's so difficult because it's a language. As Urdu was made in the plains of India and Punjab, UP and Punjab, all that area. Urdu was formed in India. Same way, Nagamese was formed by the interaction of people, in the plains wherever the tribes and everybody was getting together. So it's a pidgin of, as I said, even some Bhojpuri words are there because a lot of Bihari people migrated there for business at one time. The Battle of Kohima, in fact, Kohima can be visited to look at all the, allied forces ke cemeteries. So it's very interesting to see there. Right now, December is a time when you also see the famous festival now. Hornbill Festival, yeah, I'm forgetting the name. The Hornbill Festival is very famous. So it's interesting now that foreigners don't require a special permit to enter, but Indians require an airline permit. They require this thing like a permit to come into India. Of course, that is there, but they don't require a permit beyond. They don't require an inner line permit or some special permit for entering Nagaland. But the inner line is required for everybody because foreigners generally can be recognized, right? If people start from India, they come and stay there, so people have a problem with that. The tribal culture would be lost, so that's. Their population is said to be 19 lakhs 80,000, but some people dispute it. They say that maybe it's around 12, 13 lakh, not really. More of fudging of figures, maybe, to get more stuff from the government. Last but not the least, I'm talking about Tripura here. This was about to be joined with East Pakistan at one time, but and because 1947, the king of that place died and there was a vacuum and his son was, I think, 12, 13 years of age. But it really took the guile of Sardar Patel to keep it with India and Nehru all combined. They managed to get it into India. So that's one of the reasons why it's surrounded on all sides by Bangladesh. So it would have been difficult to maintain this except through a small area of land. Interestingly, the Agartala, which is the headquarters of Tripura, the state capital, the airport of Agartala is only about 1 kilometer by road to the Bangladesh border. Just 1.5 kilometers. You can actually see Bangladesh from the edge of the airport. And that's where a lot of Mukti Bahini camps were there for the Bangladesh Liberation War. %70 population today is Bengali speaking. Bengali Hindus a lot, 60% are Bengali Hindus, another 9% Bengali Muslims. Lingua franca today is Bengali. although Tripuri, with the tribal language is very similar to Bodo and Garo, and so they can speak to each other within a very short period of time and they can understand each other. Their death rates and IMR is comparatively higher than some other places. But yes, birth rates are down to 15.3 per thousand population. But the second highest population in the Northeast after Assam with about 3.4 crores, this is about 10% of that. Yes. I'll just try to take you back to the Northeastern slide where I wanted to. Yeah, did I write? No, before this. Yeah. People keep thinking, there are lots of people who say, oh, our Northeast is totally Christianized already. Around 15% of population only is Christian. Huh? Simply because the population of these states where I said Christians are majority is so small that overall in the Northeast, it doesn't figure anywhere. And that's why all over India, Christians are only about 2.5%. And they've maintained 2.5% since independence. They've not really increased. But then people will make you believe that, oh, Christianity is spreading like wildfire. It's not actually population-wise. It's still at 2.5% all over. And in Assam, in the Northeast also, it's about 15 to 16% overall population. Right? Yeah, I think that's about it about the Northeast. I wouldn't like to go anything beyond, but if I missed out something, Inakshi, please add. Oh, did I? Oh, sorry, I forgot Sikkim. Sorry. I forgot the younger brother. Yeah, so here, Sikkim. Yeah. Yeah. So Sikkim till 1975 was part of Tibet, under the rule of Tibet, and in that sense, obviously under China. And this is the only place where we don't say it merged with India. We still use the word and quite openly annexed with India in 1975, I think, yeah. Today there are 6 districts, but just 610,000 population. Aaj must be around 6.5 lakh population. They have promised to be the ideal state of India. That's their vision, to show India how good governance can be and how a state can, government can look after its people. So I've seen it transform in the last 15, 20 years. Very clean. Official claims, absolutely organic agriculture now. Hardly any inorganic agriculture. It has its problems about, the roads and rain and gets cut off every now and then, and they have to pass through West Bengal. The airport also is not very well connected and just been freshly cut. So doesn't even have a decent airport. So it has its challenges, but they've done quite well in the last 15, 20 years, removing plastic from most of the places. Community-driven approaches against plastics, against smoking. You can't smoke so easily. I mean, for a long time in the open also. I mean, even hotels will try not to allow you to smoke, literally, because they want to keep the environment absolutely clean. You can, I mean, in your own room, you can probably smoke, but not anywhere else. You will not be allowed to. So, and as you can see, the northern areas are very Buddhist and very sparsely populated. Most of the population is towards the south and towards the west. And that's why a large part of the population is Nepali speaking. At some part in history, it was also under the Bhutanese kingdom. And Tibetan, of course, I had talked about, but towards the latter, before Britain came anywhere nearby, it was under Bhutan that time. Whole of Assam, actually, we have a concept of dwars. You must have heard of Alipur Dwar. So we have Chirang Dwar. So we had the Kuch Dwar. So these were dwars which were basically the doors. Dwar is door also, no? So for the hills. And Bhutan used to send, raids across to the plains, loot and go back. A lot of the Bhutanese kings used to do that, and that's where they used to earn money. So then when the British came, they brought this, and it was quite common at that time. Even from Mizoram side, they will, send, the tribals will come down, loot something and go back, and then you can't, and they were on the hills, you can't. So British brought this treaty with them, that's okay. In your areas, we will not allow anybody to settle, people will have to take permission. So that's how this inner line actually came up. It didn't come with the government of India. It came before that outsiders will not we go there. So, but you pay our taxes every now and then, and we will not disturb you. So that has been the history of the hills of Northeast to some extent. Here also, now Bhutan is even as late as 1950s, we have documents from Bhutan where Bodos, you have heard of Bodos, I think,
Yes.
So we worked with Bodos mainly. So Bodos were slaves, and one department was transferring slaves from one department to another till 1950s. Right? So ye sare mein slavery also continued. Arunachal, people believe that there's still a semblance of slavery there, right? Not officially recorded, but so there has been this kind of slavery when one tribe to another, one tribe to the plains people, that kind of thing. But today, by and large, modern democracy has taken place, but there is a lot of autonomy of languages, of culture. So some of these practices remain, right? So Sikkim IMR is one of the lowest in the country, 6 per 1,000 live births, right? So as I said, one of the well-functioning governments, even the death rate is down to 4.8, which is again one of the lowest in the country. But it's a small state. We know that I think the smallest district in Assam today would be around 5 lakh population. And here there's a state with 6 lakh. If you look at Gandhi's Champaran in Bihar, the Champaran, East and West Champaran district today, their population is more than 1 crore. 2 districts, right? So in that sense, having a state with only 6 lakh population, obviously it's better governance in one sense, far easier to govern. Yeah, any questions, anything, we can please shoot up. I didn't want to show you videos and all. It's very pretty place, a lot to learn from. As I said, you will not see scratches on cars very often. People are disciplined on the roads, especially in the hills. Mizoram, you'll not find honking at all. You will rarely find a jam for more than, say, 10 minutes or so. Right? So, and as I said, Mizoram, I mean, even today, I would be proud to say that practically nobody would have heard of somebody paying a bribe. Maybe in contracts and all, yes, but otherwise for ration, pijli, pani, land, documentation, this, that, you don't have to think of a bribe there, right? And so there are cultures there which we can learn from, and that's where a person like me loves to stay in the Northeast. I made my home there. And other places also, the jhagdas that we keep hearing, har dusre din kuch na kuch hota rehta hai wahan par, is because people are still not individualistic. One person's problem is everybody's problem. So people tend to fight together for a cause. Yeah, you can call it tribal, but not tribal as a derogatory form. No, I feel it's a better form of community
That's
life.
why their public health is good, I suppose.
Pardon?
That's why their public health is good. Like the indicators are good there. Maybe
Yeah,
like
they're catching
one-
up. They're catching up on the bad figures also lately. Don't worry about that.
Maybe. Yeah.
It's also because a lot part of the hills, as I said, are still not very well connected. The migration is not there, so generally people are immune to most of the diseases there, so they don't get so many infectious illnesses that others see in other parts of the world, right? Yeah.
For traffic I was not able to get the infant mortality figure. Okay.
15. Our next session will be a bit on statistics and how do we get health statistics from various sources. We'll be dealing with that. So any questions up till now on the Northeast especially? I mean, it's not about public health. It was just our agenda to also introduce the Northeast to you.
This inner line permit is
Yeah, just use the mic so that others are listening.
So the inner line permit, you said it's different for different states, or is there
Yeah,
one way?
no. Different to different states.
It's like their prerogative who they will allow or not. Like,
Normally, they will allow everybody. It's just that, I mean, you should know, 7 days, 10 days, 1 month, or for business visa, some business ILP, sometimes 2 years together. Yeah.
so every time you go, you have to apply for a.
As I said, I mean, if it's like 2 years, then multiple entry kind of a thing. Yeah. And you
How
have to
can
pay
I get an
extra fees.
opportunity to work there? Like, after listening to all this beautiful things about the Northeast.
Oh. In one sense, yes, but typically very little corporate sector has come there, hardly any, because there was insurgency till very recently. Even now there is a bit. So industries and all have not come up. So in that sense, jobs are less, only government jobs are there. And then
Okay.
many of these places would have reservations for their own people. So yeah, as volunteers, lots of opportunity. Yeah, for as regular jobs.
Not as volunteers in this age now.
No, I'm just saying,
Yeah.
I mean, not typically, I can't say, because a lot of people migrate from the Northeast to other places. It's because typically jobs are less. And English education and education has been quite high comparatively. So there aren't too many opportunities there.
So what there is this ISB, Indian School of Business, and all. So they're running some projects there, especially in Meghalaya and all. So have you any knowledge about those projects, or you work with them in any way?
No, I didn't know about the ISB. I know that there's an IIM in Shillong now, and Meghalaya over the last few years has invited a lot of NGOs and academic institutes from across the country to help them in developing faster. But I don't know about this ISB project especially.
Mm-hmm. So it's an Indian School of Business. They're running
I know,
mostly
Hyderabad.
Hyderabad and Mohali.
Yeah.
There's a lot of PPP happening.
Yeah, in Meghalaya especially.
Even as a lot of development players are coming into it.
Sorry?
Yeah, the traffic has increased hell of a lot. I think we have 13 flights from Delhi every day now. Earlier it was 1 or 2 a day. Now it's about 13. A lot of tourists also coming into Meghalaya and Assam, especially during the winter season.
Mm-hmm.
Yeah. Anybody else? Yeah.
Have you been in Islam?
You've worked in Assam for a couple of decades now. So, I mean, how did you see the transformation in the public health sector or public health per se, in reference to Ulfa and Alpha being very, dominant in the 90s, 80s, and then even in the 2000s, early 2000s, and then now declining their prominence in the region, which you also mentioned right now. So how did you see what kind of changes, what kind of policy shift, or how did the governance actually is making a shift towards better policy implementation? Thank you.
Wouldn't dwell too long on it, but and I think Inakshi will join me in this because, yeah, of course, I've got an insider view, and she's got a mainly insider view of it. When I came in, the first time I visited this area was 85, 86. I was part of the army and I was in Arunachal Pradesh on the Tawang Chinese-Tibetan border from that time. And then when I came back in the 1996, 95, 96, I would say not even 1% had changed. The roads, the bridges, everything was the same. It had much bigger potholes in those areas. Till about 2001, I would say. Things were bad. And, so the chicken and egg, we don't know whether the insurgency created a halt to the development process which was happening elsewhere in India, or whether it was the lack of development which led to insurgency because people were disgruntled, right? So whatever, things took a back seat. So the government had to show development really, But I would say, to the credit of the UPA-1 government, that's when we first started seeing a lot of rural development taking place. I think India was getting richer at that time, and so suddenly there were so many. Public health wise, I would say that the area that I was working in, about 4.5 lakh population at that time, or maybe 5 lakh for people from outside, 500,000. I mean, for you, it must be difficult to understand. 500,000 population. We had only 3 nurses in my area, whereas you're supposed to have 1 nurse per 1,000 per 3,000 population at least. So we had just 3 nurses in 5 lakh population. Now people would say it's because the militants would not allow them to. But if that was so, people like me from outside who could have been an ex-army person, cycling around in many places. Yeah, we cycled for the first 7 years. We didn't even take a motorcycle. But in 7 years, nobody troubled us. We were allowed to move wherever. We did whatever we wanted, practically, I would say. Right? I didn't even see a militant till, no communication with them till 2011-12. Right? In that sense, so to say that, so violence, I use the word that violence in the Northeast is it's a form of communication. कहते हैं ना, लातों के भूत बातों से नहीं मानते. Sometimes the center acts like that to make you, to make myself heard, I tend to bomb blast my way. And then it's sad that when you start talking to people only who have blasted you out too much, then it becomes an incentive for the next one to use the same method to voice his grievance. And that becomes a spiral. Coming back to it, 2005 onwards, when NRHM came, things started looking up. And then roads came, and the NREGA came, and lots of more activities started happening in the villages. So that, I think, started taking away people's attraction to violence. And that's where militants started losing support. In fact, the first time when I entered 96, I entered Assam, and I worked only for 1 year when my senior colleague was picked up by Alpha and killed. And we were asked to leave as part of his ransom deal, but then they said that he had already died. So just that. So we've had a truck, we've had a fracas with Alpha also. But generally, NGOs and all are allowed to work unless they feel that there's some threat from them. As I said, it was quite well known that I had an ex-army background. Yet, no militant organization troubled me till 2012. Maybe at that time also asked me for some money and I refused. And we were still allowed to continue. So it wasn't that difficult. Right? So for 12 years, no militant organization also contacted me. So things are much better now. Things are much better in the sense of violence and all. There's a proneness to violence because of the identity issue invariably. And this reservation, non-reservation, who all will get reservation. So that keeps poking its head up. But otherwise, now I think the corporate sector, all the big hospitals are there, all the big banks are there. When I first went, there were hardly anything except the nationalized banks. Today, all kinds of things are there. Yeah, transportation will take some time, roads to develop, bridges to cross everywhere. So that's taking time. Electricity has come almost everywhere. So, and with this government's push also towards the Northeast, there have been, I think, upswings and Inakshi. Faizan, please.
Keeping violence constant. Let's how are the things now in terms of health? Like we have this Ayushman Bharat and all. Like I think we have merged National Health Mission and all those things into this Ayushman Bharat. So how is it working in like this Ayushman Bharat thing there in Northeast? So as I I have read some news about Ayushman Bharat not working in especially Kashmir. So these doctors they stand they're not going to get people treated under Ayushman Bharat, especially the private hospitals. So how are things in Northeast in terms of Ayushman Bharat or other pet projects of the government on health? So yeah.
Briefly, I can say that Ayushman looked very promising at one time because people could access the private sector and with slightly better, at least hospitality in the hospitals was far better in the private sector. So that was there. But recently it has taken a knock with the government saying that any services which are available in a medical college, and now we have 12 medical colleges in Assam. So if a medical college is within 50 kilometers of the area, then many of these specialties will not be permitted under Ayushman. So it has become a bit more difficult for people to use Ayushman. And then because of that, lesser income for the hospitals, and many of them are dropping out. So now very few hospitals are allowing Ayushman facilities. In the last 3 years, roughly, it has gone down compared to earlier.
That is one reason for that is like what I read is like the payment
Yeah,
the
delayed
hospitals are
payments,
supposed
yeah.
to delayed payment. So then why will they
Yeah.
do all these things? So
Yeah,
maybe
you're right.
one reason. So it is just wanted to understand in Northeast how is it, but yeah, like
Yeah, and
I think
many
more or
of
less
the
same everywhere.
and then many states, as are very far. So you require good densities of population for people to travel easily to private setups. Because the corporate wins only on usage, right? Then that's when it can get competitive. But in the Northeast, people have to travel large distances to come to a city area from where you will get a private service, right? So in that sense, Assam, the corporate hospital system has developed a bit. In the other states, it's only 1 or 2 hospitals in every place. And then people are, I won't say there is so much of hunger poverty in the Northeast of India, not much of hunger poverty, but yes, it's still an unmonetized society. Cash is at a premium. Very few jobs, so cash is not there. People can survive by keeping poultry, piggery at home and, having large tracts of land, maybe a small pond where they can fish and eat from. So hunger is not too much of a problem, except in maybe the plains a bit. But otherwise, but having money to spend, cash to spend on hospitals or the thing is slightly more tough in the Northeast. Yeah, Inakshi.
To what Sunil just said is, I think
Your voice is not audible that much.
Okay. I just wanted to add that the political turmoil that the region has seen, over the past, and of course it's a chicken and egg situation. But if you see in terms of a lot of these places feel that they had been annexed, so there is this whole political turmoil that has been there, and then after annexation there has been a lack of investment. So it add on to the whole emotion of being discriminated and the lack of identity, and then the whole identity issue of over a period of time as things have been moving, who is the more indigenous, and all of that have led to a lot of issues in the region. But by the time the central government realized and then brought in the Look East policy, and then now it's known as the Act East policy, also because we need to understand that we are 98% of international border. So being an international, having such huge international border, the neglect and the insurgency is also a threat then from the external. The other element of this being seen as the corridor to the Southeast Asia, the connectivity is far better there. In fact, most of the tribes in the region feel a lot of affinity to the people on the other side because they have relatives. It's the same tribe which is on the other side of the border and this side of the border. You have relatives there here, more than perhaps the mainland of India, where the mainland would only see them as chinkies. There have been people who are stopped from going into Bhabha Atomic Energy or in places where you think, show us your passport, are you an Indian? So having faced all of that, the affiliation to the other side of the international borders is more. So you tend to see that, okay, now there is the Look East policy or the Act East policy, which is bringing in a lot of resources to the region. Development pace has improved. But again, the word of caution should be there when you are developing at a pace which is faster than what the community can absorb. Like the issue of large dams that are coming up in Arunachal. Now, who is that power going to support? The mega dams are for the entire nation, whereas the people there are getting displaced. The environment and ecology, whether it is able to accept and absorb all that pace of development, roads are being built, bridges are being built, but does the ecological and the environmental aspects be respected in the way that it should? So that again is also creating a lot of the speed of development is also causing a lot of political instability, and the communities are again feeling threatened. If you look at the indigenous tribes, they are a very small population. So suppose I take the example of the mega dam settlement. When a mega dam comes up, the whole population comes from outside. The laborers, the professionals, everyone, and then the indigenous community becomes a minority there. A mega dam would need a 55,000, workforce, of which 80% will be people from outside. What happens to the local indigenous who is not yet trained and skilled to get into those positions, right? We're talking about tourism. Corporates are rushing in. Are the local people ready to take on that kind? Is the ecology and the environment ready to take on all of that? So yeah,
I think
development is happening, but I hope it is at the pace of the region.
I think it's going, the same thing is going everywhere now, like whether it's Uttarakhand, whether it's J&K, whether any place you take, like
Look at
the things
Sikkim.
like it's
Railways into
unplanned
Sikkim.
things, like we are cutting down trees, we are mounting these mountains and all those things. So it's the same thing is going
Development at the
everywhere.
cost of whom and what?
So yeah,
for whose interests?
We are not respecting the local traditions. We are not respecting the environment. We are not respecting the laws nowadays. So they're going for the toss. So yeah, like I think it's the same everywhere, not only the Northeast in those terms. So flaming these political crisis, pitting one community against another community, pitting one tribe against another tribe. This is going everywhere. Like this is a mass kind of a thing. Like it used to happen in Kashmir. Like we used to have protests and all those things and killing the people, and but now it's happening pan India. We used to say, we will merge Kashmir with India, like a kind of we will make in Kashmir India, but it's happened otherwise. We have made whole of India like Kashmir now. So it's it's how it is going. So yeah, so it's everywhere going same way. Yeah.
People-centered development is what we all aspire for. But then, But
it is corporate sector development nowadays. So mostly.
Doesn't think we call it, doesn't think we are all hoping that we'll have people-centered development, but then governments are very scared of democracy at times, right? Because democracy has its own ways of dissipating the energy sometimes with their arguments and with the different points of view. So everybody finally, people who are interested in money will always think of it as a top-down approach. We may keep talking about bottoms up in development, but what we have seen over a period of time has been the conversion from bottoms up to one.
And it's also who, like if we talk about people-centric, who are the people you are developing for? Is it like people asking for?
No, that's what I'm saying. So, I mean, I shouldn't be talking, but we normally talk about developing with rather than for. Right? I mean, we are not charity organizations. We are democratic organizations.
I'll tell you one thing. Like I have never seen the landslides in the region of I went to Kashmir recently. So I saw this landslides in the region, Udhampur region. So that's a kind of a plain, not that much of mountains there where that landslide happened. Okay, that took away whole of the road which was built. So then like I was thinking, who is this who are getting this development?
You also have to factor in climate change which is happening.
So what are bringing that climate change? what I'm telling,
So this development paradigm that we went for has affected climate change, and the climate change is now affecting the roads and the agriculture and everything, and we are not even waking up to it. I keep needling Inakshi that we'll probably have to work much more on disasters now, that I don't see more than 25, 30 years of civilization left. Or maybe it will happen the same way, 100 years drought or something. Because we know some very good studies which have come out are saying that the Hindu Kush Himalaya region will have only 20% of glaciers left in just 10 years. So if 80% of water is gone, how are we going to survive? We can block each other's water, but somebody will start fighting with each other then. So it's not going to be easy. And I think, so partly I've also noticed this, that we have had too many of these climate events happening everywhere. And I do understand that we have to take a different route now rather than just keep making roads. And now the government has set up an environment law that next to the borders, up to 100 kilometers of the border, you don't require environmental clearance now.
Well, arrival is
would be within 100 kilometers of the border.
So the arrival is in this this arrival hills, like they have said like 90 like 90% of the arrivals will be like now cut down or something like that. They're not identifying that as a forest. So I think new, like recently I heard about this thing. So
yeah. I mean, we have our problems with the way development is only seen, but I mean, that's also unfortunately, democracy also leads to something like a TRP rating, right? Elections are also a TRP rating in one sense. So the dominant paradigm for all of us is we slip into saying that, whenever there are big roads coming up, a faster transport or electricity coming up, when we say that's development. So that's also our problem, that we tend to associate them with development, not rather than looking at better healthcare and lesser hospitals than more hospitals. Right? Ideally, that should be development, that where less people fall ill and less people require hospitals and medicines. But then we tend to see development in a very different sense. So that's also part of the problem. And so if we say that in a democracy only the government is to blame, no, I think we also have to take part of the blame. Right? Yeah, there are very little choices for us, but yeah. Meenakshi.
Sikkim has the lowest occupancy in their hospitals and their jails. So neither people get into crime, no occupancy in their police stations and also in hospitals. So we can take a break.
Yeah, let's take a break for a short while.
Then we'll run back.
Okay. Any questions from here? Sorry, I didn't pick up questions from here. Apart from one. Okay. Want to go for tea? Then let's break for tea then, or tea, coffee, whatever. 10 minutes. So I'll just introduce you to, I mean, you might have heard of it, but I just thought I'll introduce you to a bit more. Where do you get your health information from? So NFHS, the National Family Health Survey, invariably, like Faizan had said, he'd worked in the Institute for Population Studies earlier, right? So earlier called Indian Institute, and I think now called the International Institute. Am I right, Faizan? He is not online, maybe. So can you hear me? People online? Faizan and others?
Yes, sir.
Anybody can respond? Yeah, okay, yeah. So every few years, there's a National Family Health Survey which is done. Yeah, Nirma. Okay. Can you see the screen where I put the National Family Health Survey of Meghalaya? नहीं, share नहीं हुआ है. Okay, yeah. Yes, can you see it now?
Yes, sir.
Okay. All right. So every few years, the National Family Health Survey comes. It's quite a robust thing, focused only on health. And it has various features, and I'll come to it, just run through it. And this, you will have this, it's the same table of the same thing in every state. And you also have district fact sheets also, on their websites. This is partially funded. It was always partially funded by the USAID, right? But now the government, because Trump being Trump, I think, there's been some problem. And the last NFHS, the NFHS 6 has already been completed 2 years ago, but it's not been allowed to be published up till now. So there are some concerns about it. So I'm just going to take you through the NFHS. This was the last one was, the data was from 91, 92. And the report was filed by July 21. I'll run through this actually. So there are some on, as I said, education is a very important thing for health. So there'll be various things on education. So it's now monitoring education, how much is the preschool attendance, so that it's not just about quantity of education, but the quality of education. If you remember, I had also said that first time when this study was done for the effect of maternal education on infant mortality, it started with 8th standard in Nepal, but then they found that the corresponding figure in some other countries was 10th pass. So it also depends on the quality of education. Could be 8th somewhere, could be 10th somewhere. So now by and large, it's on the 10th standard that we do. Then the fertility levels. Total fertility we have already talked about, but also, because there are nuances to it, things keep changing over a period of time. So we are looking at age at first marriage, right? So we are presuming that there will be more marriages also sometime. So what are the pregnancy outcomes? How does it affect? So if you've had an abortion, the chances are you would like to go for, right? So they look at those also. What is the teenage pregnancy? How early do people start their fertile lives? Birth intervals, what they are. So it's actually a whole thing of reproductive and mother and child health. A lot of NFHS is that. But lately it has also come into non-communicable diseases like diabetes, hypertension, all that has also started coming in the last 10, 15 years. How does son preference affect women's desire for children? So again, in those who have asked for boys, what is their fertility like? Those who have asked for girls, what is their fertility like? So we try and measure all that. What is the contraceptive knowledge? And how does it affect their fertility? Does it or does it not? All right. So these are things which can we, is it possible to zoom this a bit more? No. Possible to zoom a bit? Yeah, then what will happen, the later pages a little bit become difficult. Yeah. Okay. And what are what do people, what do women prefer? So the world over, actually, for example, oral contraceptive pills are very common. In India, it still doesn't make up for so much. In most of South Asia, I think privacy is an issue. So both oral contraceptive pills and condoms are not as much used because people might discover it, the children might discover it in the house. So women much more prefer copper teas to be put in. Or these days, an injection which will last for 3 months. So आप market गए हैं, you've gone to the market, you've gone someplace and you can get one injection done, or you've gone to see the doctor because you're not feeling well, and so you get it chupke. You go and get your fertility reduced by getting a contraceptive. But a large part, which is funny, is using abstinence for contraception. And that's a peculiar choice that South Asians prefer. It's a very interesting phenomenon in our place where abstinence is seen to be a good way of family planning. So we are also, trying to make things competitive within a state, because health is a state subject by and large in India. So, compare the district-wise choices so that one is pitted against another, and you can push them. Don't tell us that, oh, wo to Kerala mein ho raha hai na, wo to, that is not in India, or that is, you can't give us statistics. So within your own state, it's easier for people to push each other, saying that we are similar. So why can't you change things? So that's how your contraceptive prevalence is much higher in some areas and not so much in. This is infant and child mortality. So there are again two terms that I would like to. Infant mortality we've already discussed in the morning again, right? It's less than 1 year. But when we use the word child mortality, we normally means 1 year to 5 years. Under 5 mortality means including infant mortality. Child mortality, when we say, it excludes infant mortality. All right, so just remember this. And when you look at this, it says high-risk births have higher mortality rates. Nothing to be very proud of, but yeah. But high-risk births or high-risk pregnancies, both the concept these days is not very well accepted, because sometimes, unless you have a universal approach, you tend to miss. So the focus has very often been on how to, where to put your money in, where to put your energies in. So the high-risk concept has been there for many years when high-risk pregnancies. But then it becomes, in India, by and large, we say that 28 to 30% of all pregnancies will be classified as high-risk pregnancies. So you imagine in a country where about 2 crore children are being, 2.5 crore children are being born every year. So 28% to track them every month or every 2 months is quite a task for the health services. So it's not really worked. And so you tend to miss a lot. So here is where you can get qualitative information about what is happening. Are babies being delivered safely? Who is delivering them? Right? Is it a quack? Is it a trained birth attendant? Is it a doctor? So all these kinds of things are being asked for in the NFHS. So specially trained people go around asking questions. And so this is the kind of thing that is done at household level. So it's a huge exercise. Yes, there'll be people who will say, yeah, itne gharon mein, how can you find out about the entire thing? The idea in statistics, as you all know, is you have to have representative samples. So this is quite well designed, not always conforming to what we thought in the field, but then it's difficult to beat this also. It's quite scientifically quite well done, but every time they learn that how we can do it better. So how many institutional deliveries? You will see in West Garo Hills it's very high, whereas in some other areas it's not very high. So I'm just saying this. So this is, I'm just showing you from Meghalaya, but this would be the same table. If you look at table number so-and-so, it will be the same. Practically the page number also will be the same in all the reports in all the states. Page number may not be, the tables and all will be the same everywhere. So in something, it's very easy to compare. You go online, look at NFHS 5, later NFHS 6, which is actually done but not printed yet. So you can compare very easily. Right? You look at these trends in vaccination coverage, or, so can you see this? It's again, we are looking at, we hope that all children get immunized before the age of 12 months. But so then you track 12 to 23 months who all have received vaccinations, and you'll see different kind of things for BCG, which is supposed to be done at birth to start with. And yet you have, but if you notice, all of them have been improving tremendously. Can you see this? The leftmost is NFHS 1, and the last one is NFHS 5. So everywhere you have seen a rapid growth in the last 15 years or so.
Except polio, which has shown a bit decline. Or that's a given reason that we are not, I think polio has been, like the polio drops has again been started now.
No, polio, I mean, also because I think lately when you're saying polio, we are also looking at intramuscular polio. So those polios which were getting missed by the oral polio drops, they have also come into the thing. So we don't know if that is the effect of why this is being shown. A bit of a drop. Yes, I mean, polio 3 is the polio. I can't see too well. This polio 3, which has shown a drop.
Polio 3 as well as diphtheria. A bit marginal. It's not like, but
DPT.
Diphtheria 3. Yes.
Yeah. And that's a fact that we are all struggling with. Meghalaya especially. That's why, as I was saying earlier, Meghalaya government had asked us to help out in doing a study on why vaccination is dropping and how they can do better in this. Right? I won't deal with it right now. The report has just been submitted to them. And there's a cause of worry there because there's something going on in that in Meghalaya, actually. Okay, I'll look at this then. The breastfeeding. So there's data on a whole lot of mother and child health activities. And then you have tuberculosis, diabetes, blood pressure, asthma, goiter. They've got a representative sample of all these being brought out in the report. So they're measuring blood glucose at household level. So imagine, I mean, going around door to door and getting this done. Yes, in a representative sample, but still, it's quite an exercise every few years if you have to do it. So we quote NFHS quite well. SRS and NFHS, we tend to quote in all our studies whenever we are writing a paper. This is where you actually claim. It's considered quite good. Because the government's own management system, which is called HMIS, the Health Management Information System, often we don't trust it so much because the doers are putting in the data, right? So they might, the person who is cheating his work may even cheat on the data. So you're not very sure. So these are third-party sources, and that's why they're considered better. Yeah.
Sorry. That happened with the NFHS 5 also. I remember when Professor James, he was kind of like when this NFHS 5 was coming. At that time also, like there was issue with the data, like not exactly from the IIPS side, but it was like government didn't want to show some certain figures. So at that time, Professor James was there was some disciplinary action taken against him, and he was removed as a director.
We know that.
Time,
I mean, the IIPS director had to change and whatnot because they were
showing data. And he left he left the IIPS. Now he is I think in Harvard or somewhere else. Yeah.
Right. So these will keep happening, but I'm just saying it was still always considered by activists, by everybody, to be better data than the HMIS, right?
It's a World Bank, like WHO feeds on this. It's
it was funded. It was invariably funded by the USAID.
Yes.
But it has WHO sanction in one sense because these funds are taken from
it's a part of DHS data worldwide. So NFHS is a part of it. Yeah, DHS is I forgot the health surveys. I forgot the full this is a part of DHS when we talk about
the Directorate of Health Services are feeding into this, but all this is done at household level. National
it is done at household. I'm talking about like it's a comparable thing when we compare it around with the countries.
So in India, it was funded by USAID. In many places, the governments themselves fund it. In some places, the European Union funds it. So, but it's ensured almost all over the world so that, we can compare easily. But there's a good, robust methodology, good scientific rigor to it. So then they're checking about women's empowerment also. As I had said earlier, in India, we're looking at 75,000 dowry deaths due to burns probably, right? And we've not been able to reduce maternal mortality, though no new technology has come for 40 years. It's obviously somewhere, it's about women's status in society, right? We can clearly look at the links and find that, there is a correlation between that. So that's why women's empowerment is important. So NFHS is also checking about, how do women, do they have control over their earnings? Can they spend? What is their empowerment like? Can they make decisions about reproductive health? What is their hygiene like? All that they study here. If the ownership is the asset registered in the name of the woman, does she have a choice in selling the property or, acquiring property? All that. They're looking at domestic violence also. So like here, Meghalaya, they said that 18% of ever married women between age 18 and 49 in Meghalaya have experienced physical or sexual violence. Right. I'll just, these are like tables, a huge lot of tables. And I said, all the tables and figures are like comparative. They'll have the same number in all the reports or all the states. I can't read from here. I mean, is there a mic which I can talk and go closer to the screen? Oh, I can speak from there. Yeah, I think much better. Some of the others may not get. So it's like these are a household, and I mean, I'll go beyond this. Okay, I'll keep moving. This is still general data that talked about how many households and whom did they talk to, whether the household was nuclear or not. But look at these now. Access to a toilet facility, right? And they'll do it religion-wise also. So look at the social determinants, right? Whether they were tribal or caste or what, or does it make a difference or not? And you will notice that sometimes you will find a difference in the. So then you have to work out why. Is it a discrimination thing? Is it an access thing? Why is it happening? So, but I mean, if without this, we are moving around in the dark. We keep investing money thinking that it will work, but it will not work because you've not done your positive discrimination which was required, right? So that's what we were learning from the equity class yesterday. Then they will be good in some and not so great, district-wise. See, we've got lovely data on even household goods. How many households have, urban and rural areas, how many have mattresses, pressure cookers, chairs, cots, transistors, television. They're measuring everything. So they're very robust data that you can say whether they are rich or not. Kind of, even having a tractor, you will probably be able to, whether they're accessing internet or have a computer, all that is tracked all over. So I don't know how many of you have seen NFHS data, so I just wanted you to see this, that,
this household position is used to make this, wealth quantiles or wealth deciles. Yeah.
And then you can do a cross tabulation, with good statistical packages, you can do a cross tabulation of whether assets are linked to fertility, if assets are linked to education, that we can also cross tabulate that. Again, of course, it's preschool attendance, again, religion-wise and the caste, the thing. And whether the family size makes a difference or not, and you can see that it makes a difference. School attendance. So very detailed, what's the percentage in 6 to 10 primary schools or elementary schools. 6 to 10 age group, years of age group. So all this, and you will see whether what is those who are attending school or not attending school. I will just move up a bit more. See, this is about birth registration. It's very low comparatively in India. Even today, though we have allowed panchayats and local bodies to give you a certificate, it's still very low. Like rural areas, if you see, it's still 49.3. 4-5 years ago. It's very low birth registration. So your planning figures are not very good. In one of the HMIS studies that I did for Bodoland, I realized that of all the births recorded there, both in private and public, I found it was making up only 1% birth rate, whereas the birth rate was 2.08 for a son. Obviously, we're missing 50% of the births, that means, in that area. We don't know whether more women died there, more children died in those families. We don't know. So then this data is, we're not never sure of the data. We are looking at only that data which is coming to us. We've not done an active search of those data which is probably not coming to you. Right? Although there are systems in place, but it's not really happening. And that's why I say that governance sometimes is something which has to be worked on. To say with confidence that my data is correct, that my people are reaching out to everybody, or at least 90%, 80%. This is again death registration. Again, not very great, still at about 50% or so. And this, yeah. See, this is the fertility trend by residents, urban and rural. Would track both crude birth rate and TFR also. As you will notice in NFHS 5, your urban TFR, though the place is around 80% tribals in Meghalaya, more than 80%. Your urban and rural is a huge divide. Rural is 3.31, almost double, more than double of the urban. We saw it yesterday. Here it's against religion also and about caste. And this is where I pick up the data about schooling, how many years of schooling and how it affects the fertility rate. You can see that, right? It's far lower for somebody with 12 or more years completed, it becomes 1.68. Whereas people with no schooling is 4.45. Again, but when such data comes, I just want you to be careful that the same factor which is leading to no schooling may also be the reason why the child with the most children are being born. Right? It does not mean that low schooling has caused this. It could be the poverty or the distance from any nearby place which has caused no schooling and is also causing no access to reproductive health facilities. Am I understood? Don't jump to conclusions. We'll have to see many tables to be able to prove this and cross-tabulate data. Okay. Similarly here, you will find scheduled tribe at 3 compared to others at 1.67. It doesn't mean that the scheduled tribe or the Christian this thing was much higher than any other religion there. It does not mean that the religion has caused it. Right? There are other factors also at play. Here probably the tribal area, where tribals have access to a whole lot of land, right? And want more hands to work in the family. That's why the family size continues to be high, and they don't see the need for reducing that population. They have enough to eat. This is teenage pregnancy. Again, making a difference in, if you can see, teenage pregnancy in those who have not schooled at all and those who are 12 years or more busy with schooling and other educational activities, and those who are not have much higher teenage pregnancy. And so 53.6% women, I mean, if you look at marital status, talked about being having got married during teenage. I'll go to some others. See, they are also tracking desire not to have children. With women who responded, if they had one child, what did they say? If they had 4 children, what did they say? Do they want to have more children or not have children? You look at unmet needs of people. How many percentage are saying that they want, but how many people are not accessing reproductive contraception? Right. So there are very robust data which is coming out, which can help you plan. And we are in a development class only for this, that we become better planners. We have access to data. And this data is there. Unfortunately, not many people use it in planning. And I'll come to it a bit later. Look at this knowledge of contraceptive fact. 96.2% people, women, or 97 men have knowledge of at least one modern method. We're not talking about abstinence, we're talking about modern methods, right? And yet, there are some communities which are still having 3 and above fertility rate, right? So it's obviously, it's not just the knowledge which will, it's the need for it, it is the access to the services, all that which will make a difference. So each place you have to analyze what is the main reason for infertility. Down below, if you see traditional methods, rhythm, withdrawal, which is very dangerous, just the withdrawal of the penis from the sink, being used as a contraceptive method. It's still about 60% in the traditional methods. This is I'll go somewhere else. Yeah. Where are we getting the contraceptive methods? Now, I also want to mention Meghalaya has got a very good Meghalaya health insurance system. So all non-government servants, government servants have their own way of insurance, medical insurance. But those who are not under Ayushman can get a Meghalaya health insurance card. And the government funds it for the same amount, 5 lakh. So practically everybody is covered under insurance in Meghalaya. Okay. So you will see 61% people are getting their source of contraception from the government. But only about 37% are going to the private places. I'll go to some others to just run through this. This is where we were dealing early childhood mortality. This is where I quoted the figures yesterday, right? By religion, by mother's schooling, right? This is where you picked it up from. So this table 42 is for that. In all the reports will be table 42. I just want to highlight see the mother's, the birth order. One would think that children, by the time the parents are more used to taking care of a child, the lesser the birth, lesser the deaths in the second or third. But it doesn't happen. You will see if your birth order is 4 or more, the infant mortality, the neonatal mortality, both are higher. Can you see? Here? Oh, it's very difficult for me to write. Here, it's 1, 2, 3, 4, 5, the 6th row in birth order. You'll see that 4 or more births are more dangerous than here. Also interesting, neonatal mortality in Meghalaya is higher for male children than female. Being a matrilineal society, sometimes there is a reverse discrimination also. Understand that. These are antenatal care indicators where we are also checking whether, whether in the camps that are held, we call it VHNC, Village Health and Nutrition Day, every month that's held in a village. Whether people are being weighed or we are just saying antenatal care visit hai, yeah, are things happening there? Are the women being weighed? Is the blood pressure being measured? Is a urine sample being taken, blood sample being taken, and an abdomen examined? So you will see this quite very well done. In many other states, you will find this at 40%, 50%. Here it's more than 90% in almost everything in urban areas. But even in rural areas, you will find not so bad. Meghalaya has picked up in health in a very strong way in the last few years. The health and wellness centers are something which we are very proud of. pregnancies for which an ultrasound test was done. So again, though it's not considered necessary, but I think they've started tracking this also. Just run through. This is out-of-pocket expenses. That despite there being a government system, how much of money was spent by the family in accessing delivery costs? Delivery, we understand? Baby's delivery. So still you will see in a public health facility, we're talking about between 2,700 to 4,700 rupees being paid per family. So it's supposed to be free. Under NRHM, we are guaranteeing that you will get every facility free for childbirth. But we still add so much. And it makes probably no difference in rural and urban areas. That's almost the same. Right? And you find it funny that religion-wise, there's quite a bit of difference between Hindus, Muslims, and Christians, whereas Hindus are paying the maximum, the Muslims the least. I mean, but these are giving you hints at which you can go and then investigate further. After the birth of a newborn, we normally want people to be examined within 1 hour. And within 1 day, definitely, the Asha is supposed to be at home. And then 3rd day, 7th day, they're supposed to be checked by an Asha. So they're finding that out, how often did they get checked? How many percentage of children were checked within 1 hour, within 1 to 3 hours. Then those which were born in an institution, those who were born at home. So they will check all that. So again, it helps people in improving different points of because they a child has been born and he's alive. That's not enough. Right? If you really want to keep going ahead, you have to keep improving your health service. This is an interesting thing that they've tried to do now is male involvement in maternal care. Do the men even know all the risks of childbirth? Which part of maternal care did they get involved? So this is checking that and whether it makes, because now there's a theory that the more males are involved in maternal care, the lesser the chances of mother's death and the child's death. Right? So we are trying to increase men's involvement in mother and childhood. This is for young children. So this is ARI and fever for all children less than 5 years. ARI is acute respiratory infection and fever. So what's the incidence of it? As you will notice, it gets higher after 6 months. Actually, the mother's protection by breast milk is very good. The moment the child stops taking breast milk, it gets prone to infections, and that's one of the reasons why we try and give immunization within the first 1 year. We try and complete a lot of the immunization within the first year. Difficult to see data. ORS, as you know, for diarrheas. Anganwadi. The Anganwadi system is there as ICDS, Integrated Child Development Services, all over India. And it's a program which is taught even in the London School of Economics and whatnot as one of the largest feeding programs in India. And we know that it doesn't work very well in India. Right? So, but here they've tried to even look at this, whether the mothers receive any of these things. They're supposed to get even supplementary food there. BPL women are supposed to get. So all that is also being tracked here. Right? And what are the chances, whether they were educated, how many of them would go. So it's interesting to see that more rural women got this thing than urban women. Urban women would not find the reason to go to an Anganwadi center, and there are lesser Anganwadi centers in the urban areas. Anganwadi is what we call a child care center. Between 3 years of age and 6 years of age, all children can access that. and they'll get one snack and one meal free. It's available for all children, but generally only poorer children go there. So all adolescent girls can also go there, and all pregnant women can also go there for an extra meal and a snack in the morning. Children will obviously get some more health checkups and some more even education, preschool education now. Prevalence of anemia in children and in women is also checked with blood tests. Iodized salt in the household. What kind of food are people eating? Right, so you're getting all that from a whole lot of places in India. I'm just saying you can do a lot of studies, you can do a lot of interventions based on this data. It's quite robust, right? At least something better than, what, by going by guesswork. Right? We may not fully agree to all this, but imagine that we think of, even in Meghalaya, where people must be thinking of that there are non-veg people, but tribals and Christians have, so there'll be a lot of non-veg. If you look at how many people eat even eggs daily, is what, 13.6%? Women 13.6%, and men claiming only 7.6%. Eggs. If you look at chicken or meat, it's down to 6.9%. Right? Only when you look at weekly, it increases to about 50%. Okay? Can you see that? Yeah. Once in a week. But they're interviewing, if you can see, far more women they have interviewed than men. So that's why I think there's a difference, and women would know more about what is being cooked at home. Sorry, this. Again, anemia by district in women. And they've also tried to compare, is it possible that women who have more anemia also have children who have more? So the diet would be similar, and anemic mother having given birth to a child who is, might be lower birth weight. So they try to look at this also. Difficult to read this way, but HIV/AIDS. So sexual behavior, HIV testing, not a very easy thing to talk about, the sexual behavior especially. But again, a good attempt to understand how HIV/AIDS would spread later, or how much has been controlled over the period. You might know that in the Northeast we had far more HIV due to intravenous drug use. They were all porous water, a lot of drugs being grown, poppy being grown in Myanmar area, and also in the hills of Nagaland and Manipur to some extent. But a lot more heroin trade on that side, and pushing of these drugs. The last 5-6 years, we've seen it much more happening even in Assam. More drugs are coming in everywhere. So HIV/AIDS is something which we are bothered about, because it's the same sexually active population at that age, those who are also taking drugs. So it comes in through the drug use. Very few people would be actually using drugs, but the same people are sexually active at that time and tend to spread them to many others. This is prevalence of tuberculosis by age, by sex, by, looking at even exposure to smoke. That's why cooking fuel is run by the solid fuel or other fuel. Faizan, your health insurance coverage among women and men, you will see that 50 to 60% women are being covered by insurance. Although officially, as I said, anybody can get, but till the time, usually what has happened is all the government facilities have kept one person as a volunteer or somebody there, that whenever a patient comes, they will ensure that they will do the registration for it's free of cost. So government hospitals also tend to earn from the same health insurance if they get the services. So even government hospitals have put, instead of them going to a private sector, they can also get. So many of the private hospitals, the public hospitals, the PHC in charges have hired somebody or asked some volunteer to sit there with a machine and who registers, with a mobile who registers these people as they come into the. And so it's around 50-60% are already registered. So unlike what you would think that, the Ayushman is usually covering only about 30% people. Here it's around 60% because more people, the Meghalaya government also pays for the insurance. Where do they go? So again, this is very interesting because in the Northeast, as I said, very big cities only have these private hospitals. So a lot of the care is taken care of by the government. So about 60% would be going to the public sector. Screening tests for cancer. This is blood glucose levels. So about more than 85%, even the older people, 45 to 49 women, women don't have diabetes. And you'll notice here, there is no difference between those who have been schooled more or less. More or less, it's the same. 90 to 95% people don't have. Due to physical activity. Yeah, in the hills, you tend to walk a lot. And then in the hills, in the winters, you don't have too much of food also, which is available. Right? Your agriculture goes down in those things. So somewhere it compensates within the year. So we still don't have too much. In the plains, you will see a difference which has taken place. We have more diabetes coming up now in the villages. Tobacco and alcohol use. Tobacco is quite high in Meghalaya and Mizoram. But yeah, improving in the last few. Even women, you will find tobacco and alcohol use. Almost every day is 20%. Do you notice this? Very interesting statistic. The women have higher than men. Alcohol and tobacco use. Menstrual protection, whether they're using pads or not, and all that. This first because I want to show you a bit of HMIS from somewhere else. Experience of violence during pregnancy, and this is about experience of physical and sexual violence. So combined, it's about 17.9% women who are married have faced physical or sexual violence. And 83.6% is from the current husband. So, what was yesterday you saying? It's habit forming, violence also. I won't use the word addiction, but it's a kind of spousal violence, and this also is trapped. Injuries to women due to spousal violence also being tracked here. So yeah, that's this one. So this is NFHS, National Family Health Survey. You will find this, I mean, the new one having a few more things on disability also, right? The newer one just coming, and some more nuanced understanding of some of the older ones. I forgot to show you even what kind of water source are they using. That's also a table, but it's a long table and it was data, so I didn't show it to you. So these are there. Can I just see another file? Just go to Google please. Go to RHS. This is the last, this rural health survey are done every now and then, again, but maybe more Or every 10 years or so, this is done. Government is promising they'll do it faster than that, but it's also because they are upset about the NFHS data. So they are doing their own surveys now. So you'll get a lot of statistics. A lot of these people would make I think that. So you want to see how many hospitals there are, how many doctors there are in various places in different states. You'll get all that data here. Now I think it starts. So overall, how many sub-centers, how many primary health centers all over India they're talking about, and then how much percentage increase there has been over a period of time. And then as you go further, you'll find see like this. So it's quick for anybody to write a paper. You want something, this is an official source. You can get this saying that, what is the norm and then what is happening on the ground. So they kind of said that though your sub-center should be between 300 to 5, it should be 3,000 to 5,000 population, depending on tribal or non-tribal or hilly or non-hilly area, but average they've said is about 5,691. So they're not fully there, but not too far. Primary health centers 20 to 30,000, 20,000 population for tribal area, hilly area, and 30,000 for non-hilly, non-tribal area. So they've reached about 36,000. So they're trying to just show where they've reached and what they're supposed to have. Right? How much radial distance average the sub-center? 2.49 kilometers. Right? So I'll just go beyond. Yeah, everything is in Hindi and English. I'll just go to English. So this is the HMI. No, this is not HMI section. HMIS is actually done every day. Right? So some of it must have come from them, but HMIS is like an ongoing information system. Right? So every month, every day, actually, you can see it. People who are logged in. We can't log in, so we get older reports. But you can find, say, 5 years older reports still on the thing. The government has restricted it now. I don't know why, but so about earlier we could get it 1 year old, but now we are not getting it till about 4 or 5 years. But we can get for December so and so 21. I can get that. March 21. I can get for any district in India. I'll show you some of it. Right. So these are what they've shown: district hospitals, sub-divisional hospitals, CHCs, PHCs, SS, and sub-centers. Right? So sub-centers is blue. So they're covering, these are so many in the country. Right? This again, if you want to understand, what is the system now, because this also keeps changing sometimes. But this is the plan of action for the government. So down below the sub-center, and which is the most peripheral contact point, where usually they're supposed to have one ANM and one male worker, one female health worker and a male health worker. Usually in most states, you don't have a male health worker. Most states. And so some states have transformed it into two female health workers. But ideally, and all of them, even today in their duty things, it's written that they have to go to every household every 15 days. But in hilly areas, in other areas now, it's not possible to go. And nobody is expecting it, and now half the ANMs don't even know that they're supposed to go every household every 15 days. That's the sad part. So if you notice that there are something else called voluntary worker also. Right? So in malaria, in TB, they've also put up some kind of volunteers whom they train and expect them to do some work and help out their own. Because typically in an Assam village, for example, our panchayat is at 10,000 level. Right? And this panchayat will be having around 40 villages under it. So typically a nurse will have to go to at least 5 to 10 villages. And so it's not possible in a month to go to every place. So then they utilize volunteers here and there. So this is the kind of thing all over India. I mean, they're talking about what is the norm and what have they reached, correct? For again. So Uttar Pradesh and Bihar still are very high. And the government of India started choking them a bit so that they start reducing their population. Actually, that's what I feel. And that's why they have been red. But if you notice the northeast states, except Arunachal Pradesh, because people are, it's the largest state and with a small population, reaching out to everybody is difficult. We have to admit. And that's why it's, but despite that, I mean, they're showing green out there. The rest are all in blues. Tripura and Mizoram are kind of very well covered. Average rural population will move. Just look at the shortfalls. As I said earlier, health worker rates, there's a 66% shortage. And it's going higher because the government really doesn't want to spend money on male health workers. All right. At one time, these were called malaria workers. But once malaria came down, and because they were being paid from the malaria funds, so gradually there's nobody to fund them. And during UPA 1, even before that, 92, 93, Manmohan Singh said that there's no malaria, why are we having malaria workers? We didn't realize that it was because of the malaria workers you didn't have malaria. So the whole thing collapsed at that time and it hasn't really picked up. But with more and more, I mean, I think they've realized that if you want to, I think female workers are more disciplined compared to male workers. So I think that's the reason why generally all over India we find more ANMs in the force rather than male health workers. But here again, you can see vacancy positions, even for doctors, it's about 23.8% at the primary healthcare. And when this attendance is concerned, I'm also telling you that in most of our parts, PHC level doctors go only for 2 to 3 hours, maybe 2 to 3 times a week. And people overlook it because their salaries are not what they aspire for. Right? So they want more salary, so they stay somewhere far and also do private practice in many cases.
The main factor for female worker.
Sorry, come again on that?
Can be the main factor. Female worker are more female.
Workers would probably work at a lower salary. That's what you're trying to say? Yeah, possibly. Yeah, you're right. So it's easier to motivate women to work at a smaller salary than to motivate men. But today it's not too low also. I think they are getting an ANM, I mean GNM I would say. GNM today would be getting around 50,000 joining. Around that much when she joins. ANM also would be getting something like a primary school teacher, 28 to 30,000 rupees. Once she's full time, once she's in the post. Specialists as CHCs. CHCs are supposed to be there at block level, 1 lakh to 2 lakh population, where each CHC is supposed to have a surgical specialist, a medical specialist, a pediatrician, and a gynecologist. Right? Apart from some MBBS talk. But you look at the specialists as CHCs, that's surgeons 72% shortfall. Practically not happening. Gynecologists 64-65% shortage. So deliveries which are supposed to take place, cesareans which are supposed to take place at this place are not happening. Look at physicians also. I mean, I can understand the surgical facilities are difficult because you have blood banks there, you need to have good anesthetics. But you look at, almost all of it is about 68 to 82% shortfall sometimes. Can you see that? It's improving a bit, but we are nowhere there. Manpower, where they're getting it from, what is essential, what is desirable, what are the qualifications, everything is in this report. So I just thought I'll show you these. Now, this is state-wise. How there's been an improvement from 2005 to 2022. All the states are covered here. Okay, almost for functional status. We can take it with a pinch of salt, what functional means and according to us and what it means according to the local people. But do understand that at least there's some semblance of improvement which has happened. Okay, just want you to know that there is a document which is available, as late as just 3-4 years ago, which can give you all this kind of thing if you're writing a paper or trying to understand. Amount of health centers, that was personnel, and this is how many PHC sub-centers and all you have district-wise in each. Right? Building positions being made, and again, health workers at sub-centers. This is interesting. Again, Ayush, if you'll notice, I mean, for us, can you see Assam, Bihar, Ayush doctors, some of the highest. Assam, Bihar, Chhattisgarh. In Gujarat has taken off. So a lot of Ayush doctors are being used nowadays at health and wellness centers. We had allowed them in primary healthcare centers also, because part of the job of a medical officer is officer work, not just the medical. So we've never had a vacancy for a doctor. Doctor is the qualification to become a medical officer. So Ayush doctors may not be good. Ayush means Ayurvedic, Unani, Siddha and yoga kind of thing. So they may not be good at emergency medicine and all, but at least can follow policies and also oversee the operations by the nurses, the others. So in that sense, it makes a difference to the health coverage in that area. So don't think about it as, oh, the facilities have come. They may not be able to treat emergency, which really people want, but at least some semblance of delivery governance starts happening when Ayush doctors are present at least. So it's now come down to a CHO, which was the community health officer at all sub-centers, and they're being converted to health and wellness centers now. So even a nurse, a GNM, she gets to have a 6-month course now to be able to be a CHO. So again, she becomes the in charge and governance improves. And they've started. So what was one of the things which was happening earlier was we had only mother and child health services. So men were not coming, and men can express their opinion more strongly than women. So very smartly, what they've done is started giving treatment for both diabetes and hypertension at the health and wellness centers. The nurse probably will make a phone call to some doctor and then start treatment from there itself. Right? So because of that, now many men have started coming to the government health centers. So the pressure on the government to improve has also happened. So I think it's been a very good strategic move in improving systems. So this is again, you said can get all this data. Pharmacist, laboratory, anything, any kind of staff that you're supposed to see, you will find there, right? State-wise. I'll move out from here. We should be closing. Just one more one more thing I'll try and show you. HMISL, you were saying, we see, let's just go to the first one.
And what was this data, right? The one was just the one that you were looking at.
It's called Rural Health Statistics, RHS. You'll find it on the Health and Family Welfare. Just go sheet one, just go to sheet one. Good. This is what I want. This is tracked on a daily basis. Huh? So anytime, of course, we cannot track it, but the government people, anybody who's got a login ID can check all this. So this is done daily, and we get reports. I mean, as you can see, only as on 9th October is the last that I can get for my district where I've worked so many years. And for all over India also, it's practically only 2020 that you're getting. They are not allowing now reports to be seen by others till about 4 or 5 years after. So, but look at how it's being tracked, antenatal care. If you just look at antenatal care, which means for pregnant women, can we expand it a bit more? Can you enlarge it a bit more? Can people online see this? Anybody saying yes?
Yes, yes, we can see.
Okay. Yeah, right. So look at, so here they've done for different blocks of my district, Chirang district, where I work most of my time. So total number of pregnant women registered, then out of the total registered, how many were registered within the first trimester? So as early as possible so that we understand their basal blood pressure. As pregnancy progresses, they might have a higher blood pressure, but we want to see what is the basal. Then you have how many of them were given the tetanus shot, the first shot, how many of them were given the second one and the booster. So like that, how many of them were given iron folic acid, how many of them were given calcium tablets. So everything is being recorded. So you can see that if there are pregnant women registered 817, then how many of them have been given iron tablets? It's not saying how many of them have eaten. You can't track, right? So, but at least somebody has handed over. We don't know. Sometimes it could have been written and not handed over, then it's a different ball game. I mean, we can't go into the system there. But here, somebody is tracking at least what is going on. Can you just move up a bit? So, patients with hypertension detected, pregnant women, sorry. No, patient, I shouldn't use the word. Number of eclampsia. Eclampsia is a killer. It is when women get high blood pressure during pregnancy and then get fits. That's called eclampsia. And it can kill people. Some of the women have this. Then hemoglobin level less than 11, less than 7. So severe anemia can lead to deaths during delivery. So we're tracking that also. Go further, please, sir. Can I scroll down in this? No. It's many over, no? Scroll down. No, yeah. So syphilis, how many of the pregnant women were tested? Go beyond this, go beyond the pregnant women. Now just keep going down. So then it comes to deliveries, okay? How many home deliveries were done by skilled birth attendant? How many done by trained birth attendant? Yeah, earlier it was by skilled birth attendant, said doctor, nurse, or AN, and then it is by a trained traditional birth attendant or some other one. How many got the 7 home-based newborn care visits? So as I said, first day, third day, 7th day, like this. All Ashas are supposed to be going. Asha is a accredited social health activist. She's paid on outcome-based, not outcome, sorry, output-based management. The number of visits that she makes, the number of childbirths that she takes to the hospital, she gets money based on that. So this is being tracked through her. That how many of these people have attended them in their homes. Number of newborns received 6 HbA1c visits after institutional delivery, and those, if they were home deliveries, then at least 7. Those institutional deliveries where C-section was done. So can you see how many you were initially with about 800 deliveries, right? Totally pregnant women. And of that, it shows C-section like 68. Okay, that's the next one, M3. The 468 is all institutional deliveries, including C-sections. Right? So only C-sections are 68, which is actually not too bad. We say that about between 5 to 15% women will require cesareans. But if you look at private health facilities, around 50 to 75% women are going for cesareans. Right? They also tracked C-sections performed at night, 8 a.m. to 8 p.m. 8 p.m. to 8 a.m. Why? Ideally, it should be 50-50. No? Those born during the day, if it's an emergency or a cesarean, very few of them would be a planned cesarean. Most of them would be an emergency cesarean. So it should happen 50-50. Or maybe 60 in the daytime and 40 in the night time. But you'll notice a difference here. Only 4 were done at night. It means a lot of these are still planned. And then you're missing some of the real dangerous ones. And so it's very interesting how they've gone to it. But Meenakshi was asking me, does anybody use it? I wish people were using it. They don't even total up the deliveries and total up the thing. Why is it happening? They just keep feeding data. Please go down. So how many were born? How many children were born preterm before the age of 37, before 37 weeks? How many were born stillbirth? NTPs, how many were done? So all this is there. Keep going. Not this is, I will not go, but let's finish this. Family planning now. Yeah. How many vasectomies were done? Can you believe? 0. Permanent sterilization for males is about 100 times better, easier in men than in women. But you look at men having done this thing is 0, and number of laparoscopic sterilization for women is 11. It's low for both actually. Then postpartum sterilization within 7 days of delivery is 4. So again, keep going down, sir. Then it's about contraceptives being removed, contraceptives being put in. If you look at number of IUCD removals compared to IUCDs inserted, the number of IUCDs which are inserted in 8.3 is 93, right? And another 35 within 48 hours. And you will see that IUCD removed is 49. Right? So about 1/3 of all the IUCDs have been removed. IUCD is intrauterine contraceptive device, like a copper key. Then oral pills cycles distributed. This is number of oral pills cycles distributed. So every month you have to give up 1 cycle. If you look at 2,148 divided by 12, it will be like 200 women probably for the whole year. But you have 800 women being delivered. So if women have children only once or twice in their lifetime, they should be covered at least till 35 years of age with some contraceptive. So hardly any contraceptive is being utilized by women, oral contraceptive. So worldwide, oral contraceptives are very well used. In India, somehow we have not reached that level of oral contraceptive use. And oral contraceptives also have a very good side effect of regular menses, which women get into problems. Painless menses, with when you're on oral contraceptives, you don't get so much of pain during your menstrual cycles. So, but yet in India we don't have so much. Don't know really why. But I also said because oral pills there's very little privacy in the villages. So oral pills might be discovered by children or some other people, or condoms can be. That's why it's not a preferred contraceptive choice in India. In many other places, husband-wife's place is more or less private. Nobody goes into that room. But in India, everybody is walking through the room. So it's a bit of a. Okay, please. Just this one. Yeah, emergency contraceptive pills, you can see 8.15. Right? This is now catching on that if you've had a sexual encounter where you didn't want it to have happened and you missed the contraceptive, within 72 hours, you can actually give some pill for it. So that's now being placed with an ASHA, the lowest health worker, and people can use it now. Okay, go further. See, now, okay, just see what we are supposed to come. If there were 857 pregnant women and, so many deliveries, here, look at child immunization BCG. BCG normally tells you because it's at birth. On the day of the birth, you are giving it. So it should be the same. But for some reason, it is not matching. Right? And it keeps going down. Look at OPVO. It's oral polio vaccine and birth dose. It's so low, 284. Ideally, it should have been given along with the BCG. And it's oral. Injection bhi nahi dena to. So it shows a fault in the delivery system somewhere. Right? So these are all things that you are supposed to, you can see how the system is functioning by all this data. Keep going up. So everything, measles, all that you can see. Children aged between 9 and 11 months who have got measles and rubella, for example. Measles first dose can be given only at 9 months. So let's. Then you are, if you look at 9.6.1 onwards, these are about side effects of immunization. like fever or swelling of of the injection site, all that comes under AEFI. Okay. Then vitamin A, all that is also there. Keep going up now. Now then it's tracking childhood diseases of asthma, pneumonia, everything. Right? Then NVBDCP is National Vector-Borne Disease Control Program. It's about malaria, filaria, cholera, all that being tracked. Dengue also. Anything which is done by mosquitoes mainly. Come down. Yeah. And can you see adolescent health? That clinics are supposed to be there only for adolescent. Then you have TB, directly observed treatment for TB. So how many patients there are in the district, that's being mentioned. Then, this one thing, yeah, diabetes, hypertension, stroke, all that is being monitored in the district. Keep going up now. So emergency staff, I'll just rush through the. So you have a lot of data which is being tracked, but are we doing anything with the data? That's the moot point. And that's where we require public health people to kind of take over this job from the doctors who are just bothered about seeing patients. The guidance can come from people who understand data.
I also want to add, like, even when we do our programming, like if you want to do a public health intervention, so this is where you would start looking at what is the data saying, and then you have to again cross, like what Sunilji was saying, we did a study for an organization who wants to do a project on public health. And immunization, since the government of Meghalaya is also concerned because of the low rates of immunization. So then looking at which are the other dimensions because of which the statistics is so low. So like there is a lot of cultural and religious impact on the immunization of children. People are still scared. There are cult groups in Meghalaya who are saying no to immunization. Aap log immunization loge to shaitan ghusega and all of that. To that extent, there are people who are even saying
no education, no Aadhaar, nothing.
Yeah.
There's a new cult thing.
So we don't understand those dynamics seeing the statistics, but the statistics is telling a story which, as practitioners, we need to go down to the field and understand. Like what we just mentioned is BCG ke saath on birds with the vaccination, you could also put the polio drop. But perhaps the people there, अभी इतना just जन्मे बच्चे के मुंह में कुछ डालना is not going to be easy for even that doctor perhaps to do it, right? Because people are scared. There is a lot of emotion attached to it. So how do you educate? How do you build that whole strategy to be able to bring about a change on these statistics? So that is where I think the role of public health practitioners or NGOs or the initiatives are required beyond what the government is doing.
Look at this, on top 14.8.6 and whatnot. Number of blood units issued 0. Number of blood transfusions done 0. Right? It gives you this is a proxy indicator of how surgeries are going on. If cesareans are going on, surgery was going on, there must have been some blood required. It's not being happening. So it means major surgeries are not happening at all in the district. So again, this is a way you can study data. Going down? Yeah, let's go down and we'll finish. So there's lab testing also. Almost in Assam, everything is outsourced to different private agencies. So a lot more is happening, but then you have also wastage of both X-rays, CT scans, and whatnot. And now just stop. Now look at just now. Can you look at 16.6 and 16.5.6 also? Right. So firstly, you have done what has been the maternal death due to, but then it's also asking, was there a facility-based maternal death review done or not? If a woman dies, did somebody review it? Why did she die? 0. So it's tracking it, but not enforcing it. Then over a period of time, this should have improved. Right. So there are maternal death reviews, child death reviews are supposed to happen at district level, at facility level, both, to try and find out how do we improve. But again, there's nobody enforcing that it happens. The review happens. Yeah, go ahead. Yeah, these are again deaths due to things, animal bites, everything is there. malaria, dengue, kala azar, any deaths are being recorded here. Right? It doesn't mean there are no deaths there. We're talking about how many have got registered, how many of them have reported. Somewhere you come to know, the ASHA comes to know, or ANM comes to know and wants to report, and she'll report. If she feels that somebody will catch her for deficiency of her services, that the doctor, or they will not report. So, but it still gives you an indicator which is close to, because you can't go everywhere. But if you're sitting somewhere and trying to analyze this data, you can get something. Yeah, just let's finish this. Yeah. So that's where actually, that's what I'm saying. So HMI is corrected by people who are working in the system. So we tend to believe more on the SRS and the NFHS, right? But ideally, as working in the system, they should be bothered about this and self-correcting themselves. But that, because it doesn't happen, we have to constantly, periodically keep doing NFHS and yeah, just go out of this and just go out. I just one second, I just want to show this SRS. I won't go through it. Just look at this SRS first one. This is what a statistical registration system which we have in India. As I said, it's under the Registrar General of India. Every now and then they will bring up this. If you see that this has been this has come out in 2025. In fact, they brought out 2 reports, one for 2022 also and 23. Also reference here, it's given 2023. So they have brought out the births, the deaths, and the infant deaths. Just 3 things they have looked at periodically. Just run through the route. That's fine. So this is what they have done. And they've given out, which state has decreased how much for that. Just go next page and clear. This is how they track, and they've given out, which states have done better than others. So the rural-urban divide is shown. Yeah, go next page. Yeah, so and here all the state-wise is given. So this is the latest data that you can get, and which is reasonably correct, I would say. Because it's not by the system, it's a third party which is intervening and then saying it. So here, no, this the previous one. Yeah. So this is what, you don't have to go to another. So here what you can see is that you give out all the major states, then smaller states which have got less than 1 crore population. They come up later, smaller, because the data sometimes may not be perfectly accurate in smaller states. Because some villages may not have a birth at all in this year. So how will a child die in this year? So it might happen only the next year. So your data will keep shifting. So we track smaller states separately because it's not 100% accurate at times. But over 2-3 years, the average will catch up. So in 2-3 years' time, you will get the right. So sometimes you keep wondering why does it increase? For smaller states, it's quite common that one year it was lower and the next year it increased. And then the union territories also have been tracked separately. You will notice that Jammu Kashmir still comes up in the states only, in the bigger states. That's what union territories also. Yeah. This is a 95% confidence interval of, in statistics, you always say how trustworthy the figures are. So that's all. Yeah. Yeah. Finish it. This is again a rate by sex and residence, urban, male, female, photo. Yeah. And the infant mortality rate. Yeah. So this, look for SRS whenever you want to look at, latest data. Every 3-4 years, they will be doing this. Yeah, that's, sorry, brief rush into this. But what is important in this is that you can calculate if you know the state's birth rate, for example, roughly so much, the same should work for your district. So you can actually start planning that, okay, in my district, if this was the state birth rate, in my district also, more or less it will be the same. And so if I multiply it by the population, I should be able to get. If that is per 1,000 population, my district has got 1 lakh population, so it will be 100 times that. Okay. So you can plan accordingly also. Similarly, very interesting, I would say, last statement I'm making is that once I'd gone to the education in charge of Assam for helping me in malaria. I wanted to do something in malaria. Those days malaria was very, very heavy and wanted to do something in malaria through the teachers. We thought that because they are there in the villages and if we do some programs with them. They will take care and they will do the awareness programs in Manila. When I was talking to this person, the person was meant, and I asked him how his program at that time called the DPEP program for education was going on. He said everything is fine, but my education dropout rate is not improving. And I said, is it the first standard to second standard dropout rate? He said, yes. And I said, what is worrisome? He said, 75% dropout rate from first standard to second standard. And what we had found was that this 75% dropout rate, what they were talking about, when you looked at the second year enrollment of children, was equal to the birth rate of that area, of that district. So the first year enrollment was all fictitious because the government of India funds were all based on the first year enrollment. So nobody had matched the education figures with the health and family welfare figures. So you were supposed to have only, say, 1 lakh children, but you're showing 3 or 4 lakh children, and then showing the dropout rate, because based on that, you will get the number of teachers, number of schools. It became a popular conspiracy in one sense. Children will, parents will get a school very close by to their house, so they are also party to the crime. There will be more people getting jobs as a teacher, if you show more children being enrolled. And so this continued for quite some time till we actually compared this figure. Right? So we need to, so it's not just for health. These are data which can be helpful in planning many other things, whether schools, education, and it's always good to triangulate data. Not take it from one source, but 2 or 3 different sources. We'll be closer to the truth. Yeah, I'll end there. I think we've gone to 135 now. Any questions based on that? So I'm risking this, but whatever. If there are sharp questions which I can reply fast and give them up. Anybody online? No? What time do we get back with? 2:30?
2:15. I think 2:15 would be the time you can.
Is 2:15 okay?
2:30. It's like German bonnet 2:30.
Give a final time so that we can.
Yeah,
2:30.
2:30.
All right, so we meet at 2:30 sharp. Thank you.
2:30. Nirmal. Pause for 42.
So bit rushed and I was not sure because कोई इन्होंने बोला था तो मैंने कहा बस ये दिखा दें कि एक